So, good afternoon, everybody, and welcome to day two of our practical pediatric endocrine course. Many of you had joined in from around 20 countries yesterday, covering the entirety of the office pediatric endocrinology. And today we are going to focus largely about the emergency endocrinology. So, before we start the session, I'll have a quick word from people who have been involved in the program for quite some time. Dr. Mahesh has been involved right from the first program. Dr. Mahesh, please give your opinion and yeah.
Thank you, Dr. Anurag. First of all, for giving this opportunity to get participation in this third IPPEC. I think you rightly said that our association is now making a silver jubilee in this year, in that way. And from Grow India Society and Medi classes, I joined. I was the first one who attended that Kanpur IPPEC in 2011. Since then, we had many interactions. In 2017, we conducted one PPEC at Bhopal also. And then I am the one who had then with you a basic course, advanced course, and fellowship course. And I think about Dr. Anurag and the MD classes, there is a vision that was seen by Dr. Anurag in 2011 to start this type of program and include as many as pediatricians and encourage their interest uh, uh, to be seen in pediatric endocrinology. And at the same time, I think when we discussed first time with Dr. Anurag, at that time, he already told that in India, probably pediatric endocrinology is in a very neonatal phase. So we need to create something that people are really aware of pediatric endocrinology. And there are specialized courses that can also be start with this. And on the same thing, Dr. Anurag started these courses. And I think many of us really got advantage of attending these classes online and offline. And even now, in last 2 years, there are with the efforts of Dr. Anurag as a member, we are able to start FNB courses instead of the routine the fellowship courses. So now this FNB program is already started. I'm also able to start a DM course at my institute that is third in country. And I think the guidance what Dr. Anurag given as a friend, as a mentor, as an expert in pediatric endocrinology is invaluable. So I wish that your all the visions of you and Medi classes to take this pediatric endocrinology branch forward. I wish all the best from my side.
Thanks, Dr. Mahesh. Dr. Namita is with us. She's from AIMS Raebareli. Dr. Namita, your views before we start the program.
Yes, sir. Thank you, sir. Good afternoon, everyone. So this webinar spread over 2 days. I think it covers the entire pediatric endocrinology in a very comprehensive, crisp, and practical way, and is likely to be very useful for the postgraduate, senior residents, and other pediatrician and pediatric endocrinologists as well. So I'm grateful to Anurag sir for organizing this program and making me a part of this. Thank you, sir. Over to you.
Thank you, Dr. Namita. Dr. Sumana is with us from Kolkata. Dr. Sumana has been spearheading the program in the West Bengal region.
Thank you so much, Dr. Vajpayee, for inviting me. It's a pleasure, as always, to be a part of the program. I have been associated with Sir since, I think, pre-COVID days, and it's always a pleasure. I am sure all the postgraduate students, SRs, and whoever is listening to this program for the last, I mean, yesterday and today, will be very, very benefited from this practical approaches and algorithms. And Sir always makes them look and sound so easy, like he did for us as well. And I'm very happy to be a part of the program again. I'm wishing you all the best.
Thank you, Dr. Sumana. Dr. Tania is with us from Bangladesh, and she is very active and very much academic in terms of research and other aspects. Dr. Tania, your thoughts?
Sir, Assalamu alaikum to everyone. I'm really glad to be a part of this 2 days course. And as always, Sir has made it very simple. And the most important thing to me is that Sir is an inspiring person and he inspires us to learn and to know more. And I think many of us who has seen this or has participated this kind of uh, workshops or modules has subsequently get themselves enrolled in the fellowship programs and diploma programs, and that's what the success of this course is. And thank you. Looking forward to be a very successful module.
Thanks, Dr. Tania. We got Dr. Pragya Somani from Bhilwara, Rajasthan, who is one of our initial fellowship members, Dr. Pragya. You're muted, Dr. Pragya.
I definitely feel privileged to be a part of this platform to share such inspiring, which is being shared with such inspiring educators from all over the world. And when we talk about advancing medical education and creating a meaningful impact, I think Mediclasses, Grow Society, and Dr. Anurag Vajpayee sir truly stand out. We have, through this platform, you have revolutionized the way we approach pediatric endocrinology. I think it had never been in such a manner that is so easily we can just put in through protocols and get through the symptoms and signs and the values of hormones, which I think was very difficult for all of us to interpret everything. So it has been a great journey with all of you. And I think almost everywhere we have people who can help the patients through the knowledge we have gained through Anurag sir. So I think it has been great. And even yesterday and today, so many people being benefited by this knowledge. I think it is incredible.
Thanks a lot, Dr. Pragya, and we'll start the program right away. So this is the second part of the program that we are doing, which is largely focusing in terms of the aspects of emergency endocrinology, which part we are going to cover today. And today we're going to cover four major areas, which include the calcium, DSD, electrolyte, and decay, which are very common in terms of pediatric endocrinology, which we know is considered as a rare disorder, complicated one requiring cumbersome workup and exorbitant treatment. So we have realized that we have to increase awareness of pediatric endocrinology, increase accessibility to pediatric endocrinologists, and then work on affordability to really have a proper chain of improving care. So we started off with our YouTube channel, which is now available with a lot of resources, our website, which provides information about pediatric endocrinology, our fellowship program, which now has got an offline component with a large number of trainees from across the world, which have been trained, our publications and our mobile applications, which provide easy access to different aspects of pediatric endocrinology. So today, we're going to focus on four aspects. The first one session is on calcium disorder. And for that, I have a great privilege to introduce Dr. Mahesh Maheshwari, who is a professor of pediatrics at AIIMS Bhopal, and he has been a colleague for a long time. And then he is now working towards enhancing pediatric endocrine care in central India, and recently has started the DM program in AIIMS Bhopal. We've got Dr. Sumana Kundrami, who is now working as a pediatric endocrinologist and associate professor of pediatrics at KPCMCH. And she has been working a lot in terms of pediatric endocrinology there. Dr. Deepak was erstwhile a junior and now at AIIMS Delhi, and now he's working as a pediatrician at Janki Medical College, a very bright person, and he's been really taking a lot of efforts to improve pediatric endocrine care in Nepal. And Dr. Namita Mishra, who is the Associate Professor of Pediatrics at AIIMS Rai Bareilly, and she has been involved with us for the last couple of years. Dr. Tania Tofil, who just we heard about that, is an endocrinologist at in Bangladesh, and she has a lot of laurels and accolades to her credit. She has many publications, including a wonderful book, which is in fact co-authored by his father, who happens to be the first endocrinologist in Bangladesh. So I think that's something which is quite credible from that regards. So we'll start right away, and we will hand over to Dr. Mahesh to start about the overview of calcium disorders. Over to you, Dr. Mahesh.
Uh, Thank you, Dr. Anurag. Once again, welcome all the panelists for this particular session. So what we are going to talk in next 1 hour is about the calcium disorders. So when we talk about the calcium disorders, the three things that comes to our mind is the hypocalcemia, rickets, and hypercalcemia. So these are the three things. But before going on to the actual disorders, we need to be aware that what is actually the calcium physiology. So we know that almost 99% of the calcium is stored in the bone. So bones are actually the stored house, and only the 1% of the calcium that is actually play a part in all the activities or all the actions that is there. Out of this 1%, even the 40% of the calcium is bind with the albumin, and almost 10% of the calcium is bind with the phosphate. So the remaining 50% is actually the ionized calcium, and this is the most important value that plays a very important part. This ionized calcium affected ionized calcium and total calcium. That is always a debate. So whenever we talk about total calcium, because total calcium is dependent on two important things, that is the albumin, and so primarily the albumin. So whenever there is an albumin loss, just like in nephrotic syndrome, in those scenarios you may get a false hypercalcemia. And in the same scenario, if there is a multiple myeloma like picture where you get a more protein, there may be a possibility of hypercalcemia that you will see. At the same time, any change in the pH, especially the metabolic alkalosis or respiratory alkalosis, whenever there is a hyperventilation in a newborn child or in a chronic renal failure condition, when we treat by giving the bicarb, at that condition, the alkalosis resulted in increased albumin, ionized albumin, and that will result in actually the true hypocalcemia. That is, the ionized calcium will go down. So this is very important point that you need to remember. Calcium, usually there are three primary organs from where the calcium usually comes. The first is the bone. That is what Dr. Anurag usually says, it's the ATM of our for the calcium in our body. So that is the primary thing. And then the intestine, and then the renal. So there are three primary components. Bone is the primary. Intestine usually a chronic regulator. So this will not work to increase the calcium in the immediate effect, but definitely it's to maintain the chronic. Kidneys are usually not play a direct role in the calcium homeostasis, but definitely whenever there is a hypercalcemia or specifically hypocalcemia, it's primarily hypercalcemia. The burnt of hypercalcemia is seen by the kidney. So these are the three important organs. At the same time, there are three important hormones that is important in calcium homeostasis. The first hormone is parathormone, and this PTH plays the most important, and PTH affect all three organs. This PTH, the main role is to increase the calcium in the serum. So what it will do, it will act on the bone and increase the bone resorption. It will act on the intestine and help the calcitriol to increase the intestinal reabsorption of the calcium. So that is from where it will work. It will also work on the kidney and reduce the calcium excretion from the kidney. In that way, it usually increases the calcium. And this calcium, when we talk about this calcium, and this calcium at the same time, we also need to remember that there is a phosphorus also plays a very important role, because we talk about the calcium disorder, but the most important thing, the iron is the phosphorus. So what the PTH will do? The PTH usually increases the uh, this phosphorus. So in that way, it usually plays a very important role. Then the other thing is the calcium receptor. So whenever there is a calcium receptor, the calcium receptor, if there is a sensitive calcium receptor, it assumes that there is a calcium is more in the body and result in hypercalcemia. And it's suspect hypercalcemia, and that will result in hypercalciuria. So there is an hypocalcemia with hypercalciuria in calcium sensitive receptor state. In calcium inhibitory state, the opposite will happen. The body start thinking that there is an hypercalcemia, and there will be a decrease. The PTH will change, and that will result in the hypocalciuria. So there are two important things. At the same time, the phosphorus increases by PTH is only in two conditions. Whenever there is a chronic renal failure, at that time the phosphorus will increase. So whenever there is an increase in the phosphorus in hypocalcemia with increased phosphorus, it will be considered as an that was a normal reaction. So whenever both the things are increasing, you need to start thinking that probably there may be a vitamin D related effect. So in this way, this particular homeostasis will be there. Then there are clinical features. Most common clinical presentation, what we will see with hypocalcemia is the seizures. Second clinical presentation is the cardiac failure. In newborn, they usually presented with a congestive heart failure. So any newborn with congestive heart failure, we need to start suspecting hypocalcemia. Then there is an intracranial calcification. Sometimes in children, the unexplained headache may be a presentation of hypocalcemia, and cataract will be the another clinical manifestation that is there. But we also see when to do the screening investigation for calcium, especially in a preterm. We need to go ahead with the norm, see the calcium. Then in children who are less than 1500 gram children, in those scenarios, we should do the screening for the hypocalcemia. So these are the few clinical presentations that we need to take care. Then which sample we need to take? We already talked about that. What is the role of total calcium? At the same time, what is the role of ionized calcium? We said that ionized calcium is more important, but in many of the settings, we are not able to do the ionized calcium. So whenever we take the calcium, It's because this calcium is affected by the albumin level. So if the albumin is low, then there is a calcium is also be on a lower side. We should take the serum sample in a fasting state. And if the high protein is there, then there is a high calcium. We need to know what is the correction. So if there is a 1 gram of protein will come down, then there is a zero point 0.8 milligram per deciliter of calcium will go up. So in this way, you can calculate the actual total calcium in the body. So ideal scenario, if it is possible, then we should go ahead with the ionized calcium. In phosphorus, when we talk about the phosphorus, again, we need to take the phosphorus in a morning in a fasting state, because once you take eaten something, then there will be a release of insulin, and that insulin will affect the actual phosphorus value, and that phosphorus will be on a lower side. So we need to have few cautions, because in the calcium homeostasis, on detecting a calcium disorder, more than calcium, the phosphorus plays a very important in making the various algorithms which we are going to see in further cases. So whenever you take a phosphorus sample, it should not be a squeeze sample. There's no tourniquet should be applied. It should be a free flow sample in the serum. Age specific level is another important thing that you need to take care, because age is in infancy, the phosphorus level is little on a higher side. So 5 to 8 milligram per deciliter. In childhood, this is 4 to 6 milligram per deciliter. In adulthood, this is 2.4 to 6 milligram per deciliter. 2 to 4.6 milligram per deciliter. So these are the different values. So whenever you are interpreting the phosphorus, you should remember the age-related cutoff. That is the another important thing that you should remember in approaching further. Just like we see in thyroid T4 and TSH relationship, the free T4 and TSH relationship, there's a linear relationship. Here the relationship is the sigmoid relationship. So whenever the calcium will go down, the PTH will go up in a significant high level. So that is very important. So whenever we will see that calcium is on a lower side, PTH is also on a lower side, probably you are not dealing with a specific hypoparathyroidism or pseudo-hypoparathyroidism. So in those two parameters that you need to take care. So this relationship will also need to be remembered. Just like we are seeing the calcium is low, the PTH will go high. There is a PHP or hypervitaminosis will be the manifestation. Yeah. Uh, so that is one thing. Then how to approach? If this is low normal, then you can suspect hypoparathyroidism. So this table will show about how to approach hypocalcemia per se. We will discuss rickets and hypercalcemia in the later stage. So whenever there is a vitamin D related scenario, the phosphorus is on a lower side and PTH will be on a higher side. That was what was the normal clinic. What is the biochemical response that we used to see in vitamin D deficiency? You usually get the 25 OSD on a lower side. Calcitriol is also on a lower side. In vitamin D dependent rickets and vitamin D dependent rickets type 2, the phosphorus is on a lower side, PTH will be on a higher side, but at the same time, the 25 OSD will be the differentiating factor. When the 225 OSD is normal and the calcitriol level will be a higher side, you should start suspecting VDDR2. If the calcitriol is also low, then you need to start thinking about the vitamin D dependent 1. The second thing is the renal insufficiency, pseudo-hypoparathyroidism, and hypoparathyroidism. These are the three conditions where you usually see the phosphorus on a higher side. So you can see that the phosphorus is the most important. That is the first line of assessment. After calcium. So if there is a phosphorus is on a higher side, you expect that the PTH will be on a lower side. So PTH will be a lower side. You will get the vitamin D on a normal side, calcitriol on a lower side, and urinary calcium excretion will give you an idea that what the condition you are getting in the next slide. So how to approach, that is an important thing. So the first thing that whenever you are approaching a child with hypocalcemia, there are few important things that you need to roll out before going further. So magnesium and refractory hypocalcemia is one of the manifestation of hypomagnesemia. So whenever the child who is not responding on the routine dose of your calcium therapy, start suspecting magnesium on a lower side. Albumin, we already talked about. The low albumin or hypoalbumin will change your assessment. Phosphorus load in any form and conditions, especially in CKD or in some conditions, that will result in abnormal picture. So you need to rule out these three common conditions. Then you see the phosphorus. If phosphorus is high, that means it is not a very common condition. So if phosphorus high, either there may be a technicality is the problem. So probably you did not taken the sample in a proper way. If this is high, the first thing that you need to rule out is the chronic renal failure. So the first investigation after phosphorus is creatinine. If creatinine is also on a higher side, that suggests that the child is having a chronic kidney disease. Then, if the creatinine is normal and phosphorus is still high, you need to the second line of investigation is the parathermone. Again, when you are taking the parathermone is a heat labile, thermolabile hormone. You need to send in an iPPEC and the assessment in the early morning sample. So it's very important the collection of sample and at the same time the processing of sample. If this PTH is on a higher side, this phosphorus is also high, PTH is also high, start thinking about the pseudohypoparathyroidism. If the phosphorus is high and PTH is low, start thinking about the hypoparathyroidism. On the other part of this algorithm, whenever you see that the phosphorus is low or normal, it always indicate probably you are dealing with a vitamin D related issue. So if the 25 OSD is low, that means you are doing a vitamin D deficiency and you need to give a vitamin D treatment as per the guidelines we are going to discuss in the further case scenarios. If this 25 OSD is normal, then the next investigation will come in picture, and the next investigation is the calcitriol. So if the calcitriol is also low, then vitamin D is also low, if the 25 OSD is also low, calcitriol is also low, start thinking about VDDR1. If the calcitriol vitamin D is on a normal side and calcitriol is high, that means you start thinking about the VDDR2. So this is the way you can approach. And I think in the next few slides, our panelists will going to discuss about the various case scenarios. So I will hand back again to Dr. Anurag to take the session forward.
Thanks a lot, Dr. Mahesh, for the wonderful discussion. I'll now invite Dr. Alappan to start off with the case discussion.
Thank you, sir. Good afternoon, everyone. So I'll start with the case. Case number 1, 4-month-old boy presented with nephrotic syndrome. Calcium is 7.2 milligram per DL, but the child was asymptomatic. So Dr. Sumana ma'am, I would like to know your opinion regarding this case.
All right, thank you, Dr. Alappan. So basically, it's a case of nephrotic syndrome. So we must think that because of the proteinuria going on here, the albumin will be low. So as beautifully explained by Dr. Maheshwari a few minutes back, we should always correct the level of calcium to know whether it's true or pseudo hypocalcemia. So correcting for the albumin, the calcium here level will be according to the formula told by Dr. Maheshwari. So what's the albumin level here?
Albumin level is, ma'am, 2 gram per.
All right. So using that formula, I think it will come to something like 8.8, yes, something like that. So actually it's normal level. So although it showed 7.2, that total calcium, if you look at the corrected calcium, it will be 8.8. So that is one thing we should always keep in mind. So the key messages from this case would be we always should correct for albumin level, especially in cases where the protein is being lost. And ideally, ionic calcium is preferred over total calcium. However, if we don't get ionic calcium, then we should always correct for albumin if we get to the class.
Thank you, ma'am, for such an illustrative discussion. And moving on to the next case, case number 2, 4-year-old girl child presented with tetany, and this time, in comparison to the previous case, ionic calcium is 3.1 milligram per DL. The phosphorus is on the higher side, 8.4 milligram per DL, and PTH is 130 picomole per liter. And she was labeled as a case of pseudo-hypoparathyroidism. So, Dr. Namita ma'am, do you agree with this diagnosis, and how would you like to proceed with this thing?
Yeah, so we know that in any case of rickets, it will be associated with low phosphorus. But in this case, the phosphorus is high, and there are only two major broad categories which we think when there is a phosphorus is high. So it can be either renal failure or it can be a problem in PTH, either deficient or resistance. Now, what in this case, PTH was done first, but the first thing which should have been done before PTH was creatinine. So when we get high phosphorus in a case of hypocalcemia, then first thing we have to do is creatinine. Then look at the levels. If it is high, then we have to think in terms of renal failure. If it is normal, then we have to go for parathermone levels, PTH levels. Now, if PTH levels will be low, then it will be hypoparathyroidism, and if it is high, then it is pseudo hypoparathyroidism. So basically, this was a case of renal failure which was misdiagnosed as pseudo hypoparathyroidism because creatinine was not done before PTH. So if we look further at this case, the creatinine was 2.4 milligram per DL.
So what would be the practice points for our audience, ma'am, for this case?
High phosphorus along with hypocalcemia do creatinine before parathormone, and parathormone should be done only if creatinine is normal.
Thank you, ma'am. Moving on to the next case, a 1-year-old boy with neonatal seizure. Calcium is low, 5.4 milligram per DL with a phosphorus of 6.1 milligram per DL. PTH was inappropriately low in comparison to the calcium level. And he was given IV calcium infusion, but there was no response. The calcium level was not increasing. So, Dr. Deepak sir, I would like to know whether you think that this is a case of hypoparathyroidism or not.
Oh, not really. Like in the previous case, we have seen the story of albumin. So before labeling any child with having hypoparathyroid related issue, we have to rule out the basic causes like hypomagnesemia, hypoalbuminemia, or phosphate loss. So in cases who seems to be unresponsive to IV or oral calcium, we should rule out hypomagnesemia and all these. So what is the magnesium level, Dr. Alappan?
Magnesium level is low, sir, 0.42 milligram per DL actually.
Okay, so it's very low. Like in the neonate, we take more less than 1.5 milligram per deciliter as hypomagnesemia, and it's very low. So in this case, whatever amount of calcium we give, patient won't respond. In this child, we'll need to give magnesium, probably IV magnesium sulfate, in the dose of 0.2 to 0.4 ml per kg, and then we can do to find out the cause. Like in this case, we can see there is defect in GRPM6 defect, which is the defect in the gastrointestinal tract, in which the magnesium absorption is defective, and this child will need lifelong high dose of magnesium sulfate, either in the form of same ampoule can be broken, or we can give milk of magnesia or some other form of magnesium.
So,
So
sir,
the key
what
message
would be
here
your
will be any child who is not responding in ICU or seizure due to hypocalcemia, we must think of magnesium. Like in case of potassium, if hypokalemia is not improving, we should think of magnesium. Same way we have to think of magnesium in calcium also.
Thank you, sir. Moving on to our next case of 3-month-old girl child presented with seizure. Ionic calcium was low this time, 3.2 milligram per DL, and phosphorus was also on the lower side, 2.2 milligram per DL. PTH was almost undetectable, 3.4 picogram per ml, and she was diagnosed as a case of hypoparathyroidism. So, Dr. Tanya, I would like to know from you that how would you like to approach this case?
Thank you, Alapon. As we can see here that the child is having very low calcium, which led to development of seizure. And along with it, there is low phosphorus. So when there is low calcium and low phosphorus, we usually think that there should be high PTH, as because the low calcium will stimulate the PTH and there is a sigmoid relationship. And what the PTH does, PTH increases the calcium and decreases the phosphorus. What it should have been, there should be low calcium and high phosphorus. So I would always question about the PTH level, as because the measurement of PTH is dependent on many variables. That is, it is a very thermolabile small peptide hormone that should be kept on ice before measurement, and it should be transported immediately and measured in the lab. So if the PTH was kept in the room temperature or for too long, it would degrade and it will falsely give a result of low PTH.
So,
So what we should do, the vitamin D level, and as we can see that the vitamin D level is too low, which is consistent with low calcium and low phosphorus. So we should repeat the PTH assay. And what was the PTH level?
PTH level was low, very low in this case, and there was a defect in the improper transport of the PTH that was been detected in this case.
If we repeat the test with proper precaution, it should have been high. So the key message that it should be transported on ice, and low phosphorus is against PTH deficiency. It should have been higher if the PTH is truly low.
Thank you, ma'am.
Thank you.
Moving on to the next case, 1-week-old boy presented with seizure and ionic calcium was 2.4 milligram per DL. Phosphorus was on the higher side, 9.1 milligram per DL, and normal creatinine level. So, Dr. Sumana, ma'am, I would like to know how would you like to approach this case?
Thank you, Alapin. So again, a very common scenario for the pediatricians and the neonatologists. So neonate presenting with seizure, neonatal seizure, and of course the calcium is low, hypocalcemia, and the phosphate is high, and creatinine is normal. So so as per the algorithm as discussed by Dr. Maheshwari, so phosphorus is high. So the next step will be looking for the creatinine level. What was the creatinine like?
9.3, it was normal for this child.
Okay, the creatinine was normal. All right. So then we would send for the parathyroid hormone. What was the level like?
Parathyroid hormone was, ma'am, 2 picogram per ml.
Okay, so it's a very, I think it was a properly sent sample and it's really low. So of course, it's a case of hypoparathyroidism in a neonate presenting as neonatal seizure. So when we see a case of neonatal seizure with such early onset presentation of hypoparathyroidism, we should always think of Digeorge syndrome, which is a not so uncommon syndrome, and it can present with different atypical facies, cleft palate, of course, neonatal seizure, hypocalcemia, and cardiac defect. So we should always be very careful about doing a cardiac evaluation in this case too. Yes, so the key messages as shown on the screen are high phosphate would suggest a PTH defect, and any child presenting with hypoparathyroidism in neonatal period early presentation should have a cardiac evaluation done. Thank you.
Thank you, ma'am. Moving on to the next case, a 10-year-old boy presented with again seizure and low ionic calcium, 3.1 milligram per DL. And we can see the CT scan of the child that has been presented in the screen. So Dr. Namita, ma'am, I would like to know what is your approach regarding this case?
So this child has three clues. He has low calcium, seizures, and basal ganglia calcification. Often these children are referred to us with seizures, and neuroimaging is done. They see basal ganglia calcification, and the patients are sent to us. So calcium was done. So if we go to the algorithm, okay. So in these cases, you have to keep in mind the pseudo hypoparathyroidism, and we have to look for other features of this disease, which can be either cataract or brachymetacarpia or skin nodules. So when this patient was assessed, I think these features were present. Now, if we look at the algorithm, so calcium was low. Now, phosphorus of this patient, what was the phosphorus of this patient?
This was on the higher side, ma'am.
Okay, so phosphorus was high. Now, if we will go to the creatinine. So creatinine was?
Normal creatinine in this case.
Was also normal. Now, we'll look at the PTH levels. So what were the PTH levels of this patient? PTH levels were really high. It was 200 picogram per ml. So it was high. So now we have the diagnosis of pseudo hypoparathyroidism. We have to not only depend upon the investigation, we have to look at the clinical features also. So any patient coming with hypocalcemia, basal ganglia calcification, look for other features of pseudo hypoparathyroidism, and also rule out other causes of basal ganglia calcification. Torch infections can also lead to these calcification. Any poisoning like lead poisoning can also lead to that. So we have to rule out this. And if we are suspecting any calcium disorders, then we have to think in terms of pseudohypoparathyroidism and look for its clinical features.
Thank you, ma'am. Moving on to the next part for Dr. Maheshwari.
So we have discussed in detail about the hypocalcemia part. We'll now go forward with regards to the other aspects of these disorders. And I think Dr. Mahesh had to unfortunately leave. So I'll cover this initial discussion, then we'll move forward from that perspective. All of you are also requested to kindly keep your questions posted on the Q&A and the chat, and we'll answer it after each module. So we've discussed about hypocalcemia. The next important presentation is rickets, which is very common from a pediatrician's perspective. And remember, rickets is a radiological diagnosis. So before labeling anybody as rickets, always look at the X-ray, and you should be looking at three things. One is the cupping, which is the broadening of the distal end, the fraying, which is irregularity in the metaphysis, and finally splaying. Because of the pressure, the bone becomes weak, and that spread is the splaying part in that regards. Now, before we talk about rickets, we should always remember that 99% of these cases would actually be coming to a pediatrician be a nutritional ricket. So we need to understand what should be your right approach in terms of treatment. So these are the IAP guidelines, which are in consonance with many of the other endocrine society guidelines. There are some subtle differences, but the key messages out here is that they talk about daily therapy as a appropriate gold standard therapy, and the dose is approximately 2 to 3,000 international units given daily for 12 weeks. So it takes time for rickets to heal. And whenever you give somebody treatment, bones are being formed, calcium will be taking up the body, there will be a hungry bone syndrome, and therefore you will have a bone pain which may happen. When you give vitamin D, the bone will be formed, so you will also have increase in alkaline phosphatase level, which is a marker of bone formation. So bone pain and raise in alkaline phosphatase is the effect of treatment. It is not representative of lack of effect. Alternatively, when I was a student, we used to give a lot of 600,000 international units over a 7 to 10 day period. That thing is gone. So we don't talk about STOS therapy. What IAP is recommending is that maybe 60,000 every fortnightly for 5 doses is an opportunity where you want to have issues in terms of adherence or compliance. Importantly, whenever you are giving vitamin D, you should also give them calcium, because if you don't give them enough calcium, they will develop this hungry bone syndrome. So around 50 milligram per kg per day is the standard calcium that we are talking about. Very important message that intramuscular injections of vitamin D do not have a benefit. The body has limited capacity to store vitamin D. If you give too much vitamin D, it cannot go into the fat, it will go into the urine. And they are at a very high risk of developing hypercalciuria and nephrocalcinosis. Now remember, the maintenance dose basically, there is a 5 times or 7 times margin. So they've talked about 5 times therapeutic window for vitamin D. And what we are seeing here is that this allows us to have good amount of dose. But if you give too much dose, you may cause more problems than benefits in that regards. So what happens once you give treatment? Calcium may go down because of the hungry bone syndrome. ALP will increase because it's a marker of bone formation, and bone pain may happen. So don't consider these as markers of lack of response. The most important marker of response is line of healing, which is the gold standard. So when we talk about refractory rickets, which will largely be the area of discussion today, we need to understand that we need to have all the things to be there. We need to have rickets, which is a metaphysical involvement on radiology. You should have given adequate treatment of around 12 weeks that we discussed earlier. In malabsorption, you can use intramuscular vitamin D, so that is one option there. And you need to have a lack of line of healing. So this is like a Whipple's triad sort of a thing for refractory rickets. You need to have rickets, you should treat it appropriately, and you should show lack of response. Then only you consider it as refractory rickets. However, if a child comes to you at a very early age with polyuria, seizures, fractures, and severe growth failure, you should start thinking right away that there is something else which is causing the rickets from that perspective. Now, very importantly, often children are referred to us as refractory rickets because we have missed skeletal dysplasia as rickets. So this is something we should avoid. The dose of vitamin D is not adequate, the calcium is not added along with that, and high alkaline phosphatase and bone pain is considered as a marker of lack of response. So clearly, do not unnecessarily label refractory rickets, because that would mean a lot of investigations will be done in that regard. So when we talk about rickets, there could be a deficiency in calcium and vitamin D, which we can identify using therapeutic response. Refractory rickets could largely be calciopenic, in which your calcium vitamin D access is less, associated with early onset, high PTH, hypocalcemia, and bone pain. Acidosis, which basically will have polyuria, polydipsia, and also nephrocalcinosis in distal RTA, and phosphopenic form, in which basically you will have a later onset presentation, which will be there, and lower limb involvement will be predominant from that perspective. So this is an important thing to remember. If you look at the phosphorus, calcium, and PTH, 90% of your diagnosis is done in rickets. So questions are, is it rickets? Is it refractory? And what's really the cause, and how do you manage? So the workup should include phosphorus. Phosphorus is the most important investigation in anybody who has hypocalcemia or rickets. If phosphorus is high with rickets, think of renal failure and PHP. Everybody else should have a low phosphorus. Hypercalciuria will indicate distal RTA. Normal PTH despite rickets. Anybody with rickets should have a hyperparathyroidism. Normal PTH, think of a hypophosphatemic rickets. ALP should be high. If the ALP is normal, think of renal tubular acidosis or kidney disease. And rarely, if it is low, think of hypophosphatasia. Acidosis, of course, will indicate renal tubular acidosis or a chronic kidney disease. So basically what you're looking at is phosphorus. High phosphorus, your diagnosis is very, very close. Low phosphorus, you then look at calcium and PTH. If you have hypocalcemia and hyperparathyroidism, that is vitamin D related causes. Normal calcium, normal PTH, you have hypophosphatemic rickets. Hypercalciuria, directly RTA, and acidosis, again RTA or renal failure. So if you combine these basic investigations, you will get the diagnosis. So start off with obviously a calcium vitamin D trial, and then if the phosphorus is high, do creatinine to identify CKD and pseudohypoparathyroidism. If phosphorus is low, do a blood gas to exclude RTA. If blood gas is normal, do calcium and PTH. If both are normal, that is hypophosphatemic. If they are showing hyperparathyroidism, think of VGTR and then classify accordingly. Key message is a lot of these investigations can do a lot of confusion. So don't do it unless they are necessary. Very importantly, calcitriol levels are bad markers of vitamin D status, and they can be low, normal, or high in somebody with deficiency. So do it only when it is required from that regard. So we'll now move forward to the subsequent cases. Dr. Alappan.
Thank you, sir. Moving on to the next case, a 3-year-old boy with rickets given vitamin D 60,000 international unit 3 doses. Now presented with bone pain with a raised alkaline phosphatase level and calcium of 9.4. He was diagnosed as refractory rickets by his treating physician. So, Dr. Deepak sir, do you like to agree with this decision, or you'd like to change your management in this perspective?
No, first we have to look at what we label as the refractory rickets. In this case, patient has just received the 3 doses and it's inadequate. On top of that, there are some paradoxical responses during treatment we expect. One is hypocalcemia, second is bone pain, and third is sometimes biochemical markers like ALP may increase. These are actually not the markers of refractoriness, but expected events during the treatment. The best thing will be to look at the X-ray, and if I can see that there is clear-cut marker of healing in this child, like in the distal limb, so this is normal response. I don't see if this child has any refractoriness to the treatment. So this is expected normal response. Bone pain and ALP may rise during treatment. So these things may need to be considered while we are labeling refractory rickets. We have to look at the line of healing rather than the symptoms.
Thank you, sir. Moving on to the next case, a 4-year-old girl child with rickets given calcium and phosphorate liquid solution of 5 ml twice a day, but there was no improvement for she was given continuously for 30 days, and in the X-ray there was no line of healing present. So again, the treating physician thought this is a case of refractory ricket and referred the case to us. So, Dr. Tanya ma'am, I would like to know how would you like to manage this case when this patient will land up into your OPD?
Okay, we will have to again repeat the definition of refractory rickets. That was the child being treated with an adequate dose. I think they're saying that there is no improvement in 30 days. But before leveling the child as refractory rickets, the child has to be treated with full course of treatment at least for two times. So if I take into account the age of this child, then she should get 3,000 unit of vitamin D for 12 weeks, or we can give 60,000 international unit every 2 weeks for 5 times. So it was an inadequate dose. The duration was not complete, and we don't know whether the child was given calcium in an adequate dose also. That is 50 milligram per kg per day. And after all that, the earliest response we should do at least 6 weeks later. That is the line of healing. So it was an inadequate treatment. We cannot label the child as having refractory rickets now.
Okay.
So we should only complete the treatment with adequate dose and duration and along with calcium supplementation. And after 2 times, we can label the child as having refractory rickets. If there is no sign of healing, most importantly, the line of healing.
Thank you, ma'am. Moving on to the next case, this 5-year-old girl child presented with rickets and polyuria. Her weight was 10 kg, very low, and height was also on the around 2 years of age, 88 centimeter. So this is the BBG picture of this child showing a pH of 7.1 with urine pH 6.8, and she was labeled at distal RT. So, Dr. Sumana ma'am, how would you like to approach this case?
All right. So 5-year-old girl, definitely with growth failure, we can see that. And picture is kind of suggestive of RTA, but I must say that as per the algorithm, I said, what is the phosphorus like? And okay, yes. So what is the phosphorus like?
9 milligram per DL, ma'am.
All right. So high phosphorus. So then as per the algorithm, we should go for creatinine levels. What is the creatinine level?
Creatinine level was 2 milligram per
All
DL.
right. So it's clearly high. So the thing is, so since the creatinine is high, it is definitely a case of CKD or chronic kidney disease and not RTA. CKD is a way more common than RTA. And I think CKD is, of course, glomerular problem, and that's a tubular problem. So we should always go as per the algorithm. So any case with high phosphate and rickety features suggests chronic kidney disease. And we should be, actually, if we follow the algorithm, we will be able to find it out very easily.
Yes,
That's
thank you, ma'am. Thank you so much. Moving on to the next case, a 12-year-old girl child with multiple fractures. You can see the X-ray picture as well as the clinical picture of this child. And he presented to us with failure to thrive, polyuria, and myopathy. Dr. Namita, ma'am, I would like to know, how would you like to approach this case?
Okay, so with this clinical features, I think first differential which will come into our mind will be osteogenesis imperfecta. But then we have to remember that we have to look for the causes of refractory rickets also, which can be there. And in this case, we have the suggestive features. We have failure to thrive. The child is having polyuria, myopathy. So we need to work up in terms of rickets also. So what was the phosphorus level in this case? Phosphorus was normal. It was low, nearly low or normal, we can say. Then creatinine was normal. So if we look at the algorithm, if phosphorus is low, no or normal, then we have to look for the blood gas. Now, in this case, your blood gas was showing acidosis. So pH was 7.12. So if we proceed to the algorithm, acidosis, and it is coming as RTA. So probably in these cases, distal RTA will be a probable diagnosis. Proximal RTA can also be, we can consider, but then we can differentiate on the basis of some features. Like one is that proximal RTA, they present little earlier, and the acidosis is little mild, less milder than the distal RTA one. And then the final test, we have to do the acidification test and look for the urine pH. So in this case, urine pH, as I can see, it is 7.4, that is more than 5.3. So that means there is no acidification happening. So this is going more in favor of distal RTA rather than the proximal RTA. We can look at the urine calcium levels also to confirm the diagnosis. So key messages coming out of this case will be that multiple fractures will indicate distal RTA. In a case where we are suspecting a refractory rickets, obviously along with refractory rickets, we have to look for other causes. We should also think about other causes also.
Thank you, ma'am. Moving on to the next case, a 14-year-old boy presented refractory rickets. You can see the clinical picture of the child as well as the X-ray picture. Dr. Deepak sir, I would like to know your interference from this case.
So we can see the 14-year child who looks just like 9-year or 10-year on the photographs. On top of that, we can see there is bilateral lower limb deformity in the form of valgus. As compared to the upper limb seems okay. And the X-ray, we can see there is not so gross changes of rickets, subtle changes of rickets, and like cupping and slight splaying is there. Some cortical thickening is also there. So it doesn't look like so very classical of vitamin D deficient rickets, and the lower limb involvement more than the upper limb and late presentation. So it looks something else than the vitamin D deficiency, and we have to work up this case for, like, this child might have received tons of vitamin D, I guess.
Yes, yes, sir.
So can you please narrate me about the phosphorus and creatinine in this child?
So phosphorus level was low, 1.8 milligram per DL, and there was no acidosis present.
Calcium?
Calcium is also on the lower side, not lower, it's on the normal side. This case.
And the child does not have any calciopenic features like tetany, muscle weakness, cramps?
No, sir, not present in this case.
Okay, so in this case,
and PTH was 12 in this case.
Okay. So there is no acidosis, no hypocalcemia. So this clearly points towards hypophosphatemia along with normal PTH, I can see. So clearly fits into the hypophosphatemic rickets suggested by lower limb involvement more than the upper limb presentation, hypophosphatemia. So we have to manage in the line of hypophosphatemic rickets in the form of oral phosphates.
I would like to request everyone to please keep mute your device.
Okay. So this child is not having any vitamin D deficiency, rather phosphogenic rickets in the form of hyperphosphatemia. We have to work up on the genetics to find out the exact cause. Most of the time it will be X-linked hyperphosphatemic rickets, and this child will need phosphates and active vitamin D, that is 125 or calcitriol. And these days we have monoclonal antibodies like durosumab, which is not so easily available in the developing country. But if that's available, that is good. So this child will need Julie solution along with active vitamin D.
Thank you, sir.
Thanks, Dr. Alapan. We'll move over towards hypercalcemia, which is considered to be a rarer diagnosis, but then there are other features which are very important not to be missed. So hypercalcemia should be considered in the presence of severe dehydration, polyuria, hypotonia in the neonatal period, and encephalopathy. So it's a differential of any sick newborn. You should always measure sodium, calcium, and glucose. So hypercalcemia, as I said, in older children will present more with abdominal pain. So in adults, we talk about moan, groan, and abdominal pain. So you will have pain in the abdomen, you will have stones, and there will be bone pains. Also, hypertension is common and calcification becomes there. And of course, you can have a metabolic bone disease, which may also present. So if you want to classify hypercalcemia, again, a most important investigation is phosphorus. Yesterday, we discussed about how weight was most important in somebody who has short stature, how height was most important in somebody with obesity. Similarly, for hypocalcemia, rickets, hypercalcemia, rather than calcium, we are looking at phosphorus. Anybody who has got hyperparathyroid related cause, you expect the phosphorus level to be on the lower side. While if you have a high phosphorus, high calcium, that is vitamin D related, whether it is exogenous vitamin D, whether it is increased conversion to calcitriol, or whether there is a granulomatous disease. So if you have low phosphorus, you're mainly looking at hyperpara. PTH will give you a clue. If you have hypercalcemia with hypocalciuria, you're dealing with a calcium sensing receptor defect. While if your phosphorus is on the higher side, then you start thinking of vitamin D excess, granulomatous disease as an important cause from that perspective. Always interpret PTH in the light of calcium. We just discussed, Dr. Mahesh talked about that if you have hypocalcemia, PTH should be more than 70. Similarly, if you have hypercalcemia, PTH should be less than 20. If you have high calcium with a PTH more than 20, which is inappropriately normal, that is hyperparathyroidism. So first evaluation after you have ruled out drugs and immobilizations to look at PTH. If PTH is high, urinary calcium will classify it into a calcium sensing defect versus hyperparathyroidism. While if your PTH is low, then mostly you're dealing with the vitamin D related causes, which may be exogenous, or it can be because of a granulomatous disease in which you will have a higher amount of production of 125 hydroxylase from that perspective. So we'll again go through the calcium cases, Dr. Amata.
Thank you, sir. This 12-day-old girl child with irritability presented with dehydration and a high calcium level. Dr. Tanya ma'am, I would like to know your approach in this case.
Thank you, Alapon. As we can see that the calcium level is very high in this child. So what we should do next, we should go for a PTH level.
So PTH was high in this case, 120.
And that is also very high. So this high PTH is driving the high calcium level. So next we will see whether the urinary calcium is high or normal.
So this is the urinary calcium creatinine ratio, ma'am, that is present in our case.
The urinary calcium creatinine ratio is low. That means the kidney is not excreting enough calcium here. So that leads to the diagnosis of calcium sensing receptor defect. And it is a very severe defect. So what we should do, this is the severe neonatal severe hyperparathyroidism. So we should actually treat this hypercalcemia with acute management, and then this child should undergo parathyroidectomy. As because it is a life-threatening condition, and we should also investigate the parents if they have any heterozygous mutation in their calcium sensing receptors. So we should also look for the urinary calcium creatinine ratio in the parents also.
Thank you, ma'am.
Thank
Moving on to the next case, the 2-year-old girl child with abdominal pain presented with a ultrasound picture of nephrocalcinosis present, high calcium level and a higher phosphorus level in this case. So, Dr. Sumana ma'am, I would like to know how do you like to approach this case?
All right. So, nephrocalcinosis in ultrasound indicating, of course, hypercalcemia and calciuria, and we can see the calcium level is high and also phosphate level is high. So, next up, as per the algorithm, we should go for the parathormone levels. What is the okay?
Level is
It's low. All right. I would like to look at the vitamin D because ideally, okay. So it's really high because I was expecting a yes. So because both are on the higher side, both calcium and phosphorus, we have to look at the vitamin D levels, which is clearly high here. So it could be a case of vitamin D excess or vitamin D toxicity. Yes. So it's a very, very, I mean, not very uncommon, but very fatal condition. And we, as clinicians, should be very aware of this condition. And sometimes it can be asymptomatic too. And with the increasing awareness of the, people are taking vitamin D like over the counter medication, left and center. And there's also unregulated fortification of cooking oils. And there has been a recent case report from, I think, PGI Chandigarh. So yes, it's a very interesting case. So the key messages here from this case would be high phosphate and high calcium would indicate vitamin D excess, and you would be very careful about it. Of course, it needs proper hydration, bisphosphonates, and even steroids as treatment. Thank you.
Thank you, ma'am. Moving on to the next case, this 15-year-old girl child, a preterm child with 28 weeks of gestation, calcium level of 14 milligram per DL with a lower side of phosphorus level 2.8 and undetectable PTH level. So, Dr. Namita, ma'am, I would like to know how do you like to manage this case?
Yes, so we have hypercalcemia with low PTH levels. So after first ruling out that PTH was done properly in a proper, it was transported in a proper ice bag and was immediately processed. So if that is okay and PTH are still low, hyperparathyroidism is definitely ruled out. So if we look at the algorithm, so next step will be to do the 25 OHD levels, which in this case, as I can say, is nearly normal, low normal. So in that case, next step will be to do the calcitrol levels. In this case, calcitrol levels are really high. It is 125. So in this case, although the algorithm is showing granulomatous diseases, now we are dealing with a 28 weeker who is more likely to be on total parental nutrition. So in this case, this baby was on total parental nutrition. In TPN, if we give calcium and do not give phosphorus along with that, then this condition may arise and it will lead to hypophosphatemia along with hypercalcemia, and it will cause problems with the baby. So it's very important that when we give TPN to these children along with calcium, we should always think of adding phosphorus. And this, as I said earlier, only that since PTH was very less, so hyperparathyroidism is excluded. We should always consider low phosphorus in hypercalcemia.
Thank you, ma'am. Moving on to the next case and the last case, probably the 4-day-old boy with seizures, birth weight of 3.2 kg, having a history of birth asphyxia present, calcium level is 18 and phosphate level is 4.2 milligram per DL. Again, an undetectable PTH level. Dr. Deepak sir, I would like to know how do you like to approach this case?
Okay, so we can see from this case, child has seizure along with hypercalcemia, but fortunately PTH is very low. So there is something else which is driving hypercalcemia. So in this case, first we have to look what are the other baseline investigations besides any recent history of drugs which can cause hypercalcemia. In birth asphyxia, there is one condition called subcutaneous fat necrosis that also we have to examine carefully. So can you give some light on the physical examination finding and baseline basic investigations?
Yes, on physical examination, there was a palpable nodule present and the biochemical picture of 25 OSD and calcitriol has been given, sir, here.
Okay, so we can see the 25 OSD is more or less normal, but the calcitriol is very high. So it means there is something else other than the PTH driving the conversion. So in subcutaneous fat necrosis, there can be activation of from vitamin D to calcitriol because of the enzyme present in that tissue. So in this case, we have to treat with diuretics, fluids, and possibly a steroid also. And in uncontrolled cases, we can give pamidronate or like that. So in any child who is having birth asphyxia or is going for the cooling, we should clearly look for any fat necrosis, which can look like erythematous or biolysis nodule, and we have to investigate. It's not only the hypocalcemia who can cause seizure in birth asphyxia patient, but sometimes hypercalcemia can also. It's so very important to monitor the calcium frequently.
Thank you, sir.
Thanks a lot, Dr. Alappan, for really coordinating the cases nicely. We will go to the various questions if there are any, and I'll encourage all the participants to keep the questions in between. Dr. Narendra is asking, as the hypervitamin of vitamin D may go unnoticed, it is mandatory to do vitamin D3 level after 5 doses of vitamin D. Not necessarily. So when we're talking about this therapeutic dose of 60,000 international units, the risk of hypercalcemia is very, very rare. There is a rare condition in which you may have a problem of 25 hydroxylase deficiency, in which you cannot inactivate the vitamin D. So there, all of it will go into the activated form. So 24 hydroxylase is not there. This is a cause of idiopathic hypercalcemia of infancy. So if you give vitamin D and a child develops, even at a physiological dose, develops polyuria and other abnormalities, you should start thinking that there may be something else which is going on from that perspective. So that case we need to be a bit cautious about from that regards. So that is the scenario we need to worry, but don't do it routinely in everybody from that perspective. So with that, we come to the end of the calcium session. I'd like to thank Dr. Maheshwari, Dr. Deepak, Dr. Sumana, Dr. Namita, and Dr. Tanya for really going through the cases wonderfully, and Alappan for coordinating the cases. And now we will be moving towards the second important talk, and that will be about disorders of sexual development. So before Dr. Dhwani starts, I'll just introduce the entire panel, and then Dr. Dhwani can take over from that perspective. So this is a very, very important module of disorder of sexual development, because that is something which is common. It's an emergency which is there in that regards. It's a pleasure to introduce Dr. Dhwani, who has been a fellow at our place and is now working as a consultant pediatric endocrinologist at Amrit Hospital, Chhapra. She has been doing work on DSD, the DSD interpreter, which was presented and awarded at APES 2024, as well as SP conference. So she is doing work on this particular field from that regards. Pratik, again, a very, very great to introduce him as well, who has been a fellow here and who is now working currently as a clinical research fellow in metabolic bone disease in Birmingham, UK. He has a lot of interest in bone health in various aspects from that perspective. Dr. Varsha, who is from Pakistan, she is assistant professor pediatric endocrinology and diabetes at Jinnah Sindh Medical University. She will be part of the panel. And Dr. Yasmin Akhtar, who is associate professor and head endocrinology at Bangladesh Medical College Hospital. So this is going to be a very interesting panel from that perspective. And I will now ask Dhwani to start off the presentation from her side.
Thank you so much for the kind introduction. Just a minute.
Yeah.
Thank you so much for the kind introduction. I am grateful to Anurag sir and Team Regency for giving me an opportunity to speak at this platform on a topic so dear to my heart. So, sexual differentiation involves a series of complex events whereby sexually undifferentiated gonad and external genitalia serially acquire either male or female characteristics. Now, this depends on your chromosomal makeup and genetics, what gonads are formed, the ability of these gonads to form the required sex hormone, the ability of these hormones to act on their end receptors so that there is differentiation of your internal as well as external genitalia. More importantly, these hormones also play a role at the level of brain to create a perceived gender identity in every individual. An important thing to remember is that your gonads are derived from your urogenital axis, which is also responsible for development of your kidneys and adrenal glands. Therefore, defects in the gonad may be associated with concomitant abnormalities in your kidneys and adrenal glands. Coming to XYDSD, so XYDSDs are due to act of omission. Anything that goes wrong along this pathway of virilization of a boy will result in any omission in this pathway will result in an undervirilized male and an XYDSD. So if you have problem at the level of chromosomes, your gonads, your hormone receptor, any of this can result in XYDSD. Another important hormone, which is although not essential for virilizing a boy, is your anti-Mullerian hormone produced by the Sertoli cells. It comes in very early in fetal period and is responsible for regression of Mullerian structures in an XY individual. So when you have defective AMH levels in an XY individual, you will have persistence of uterus. Whereas most cases of XY-DSD have no uterus due to proper synthesis of AMH hormone. On the other hand, your XX-DSDs are due to acts of commission. So you know your default setting when no other hormone is coming in, your external genitalia will develop into a female. If there is anything coming in which causes virilization of this individual, it will lead to an XX-DSD. This virilizing hormone can either come from your adrenals, which is your most common congenital adrenal hyperplasia. It could come from your gonads, which could be either genetic causes or conditions like aromatase or luteoma. We will be talking about it subsequently. Most importantly, XX-DSD will have Mullerian structures and no gonads. So your DSDs can be broadly classified as XX, 46XX DSD, wherein you have no gonad in presence of Mullerian structures. These are due to androgen excess, either from an adrenal source due to congenital adrenal hyperplasia, or from an ovarian cause, which may be caused by aromatase deficiency or luteoma. You may also have gonadal dysgenesis due to SRY gene insertion, SOX9 defect, or FOXL2 defects in a 46XX individual. Moving on, your 46XY DSDs, you have palpable gonads but no Mullerian structures. So causes of XY DSD include gonadal dysgenesis due to NR5A1 defect, which is associated with adrenal problems, WT1 associated with concomitant renal abnormalities, or due to SRY gene deletion. XY-DSD may also be due to impaired androgen synthesis or action. So your impaired androgen synthesis is due to proximal defects, which may or may not be associated with concomitant glucocorticoid-mineralocorticoid axis dysregulation, or they may be due to isolated testosterone biosynthetic defects like 17-beta HSD deficiency, or moving down the pathway, you may have normal testosterone production but impaired conversion to DHT, as with your 5-alpha reductase 2 deficiency, or you may have normal production of testosterone and DHT but an impaired receptor action resulting in androgen insensitivity syndrome. Last up, you have sex chromosomal disorders wherein you have both your palpable gonad as well as Mullerian structure. Now, these individuals may have ovarian tissue, testicular tissue, or ovotestes. So, who is DSD and who needs to be evaluated along these lines? If you have an apparent male, a phenotypic male with bilateral cryptorchidism, severe hypospadias, especially penoscrotal hypospadias, or if you have hypospadias with undescended testes or micropenis, then this individual needs to be worked up along lines of DSD. Similarly, if you have an apparent female with inguinal or labial gonads, with labial fusion and a anogenital ratio greater than 0.5, or when you have clitoromegaly more than 1 centimeter, also think of DSD later in life when you have pubertal virilization in a female or primary amenorrhea in a female. Okay. So what all things will you look for on examination? You will look at the phallic length. In an apparent male, if your phallic length is less than 2 centimeters. In an apparent female, if your phallic length is more than 1 centimeter. Palpate for erectile tissue. Look for palpable gonads. They are felt as round rubbery tissue in the inguinoscrotal regions bilaterally. Sometimes, very rarely, it could be fallopian tube, and that is palpated, but usually it is, if you feel around structure, it is most likely testicular tissue. Look for genital asymmetry. Does the genitalia look, there are instances wherein one side of the genitalia looks like labia and the other side has more rugosities like scrotum. So if you have genital asymmetry, it could be a soft sign that this is an ovotesticular DSD. Most importantly, and last but not the least, look for Mullerian structures. They can be palpated digitally, and on digital per rectal examination, they are felt like cord-like structure in the midline anteriorly, but a more convenient option and something that you can easily identify in the neonatal period is with a pelvic ultrasound. Because of the effect of maternal estrogens, in a female fetus, you can easily identify uterus in the early neonatal period, right? And to highlight how important physical examination is, or your clinical examination is, I want to highlight a case that we had encountered at Regency. So we had this international patient who was found to have no palpable gonads, underwent multiple ultrasounds, some showed doubtful Mullerian structures and some did not show Mullerian structures. Was assumed to be an XX-DSD, started on keeping a high suspicion for CH. The child was started on hydrocortisone, fludrocortisone, and couple of weeks later, the karyotype report came out, which was 46XY. The treating team was confused and requested the family for a repeat karyotype, considering that there was some lab error in the karyotype report, and that is when the family sought consultation with us. At their first visit, we were able to find gonads in bilateral inguinal region. A repeat ultrasound done at our center showed no Mullerian structure. So what was once believed to be an XX-DSD and treated along those lines, the game completely changed with rightful clinical examination. Eventually, the genetics came out to be 17 beta HSD3 deficiency in this child. So moving on, clinically, if you have no palpable gonads and Mullerian structures, you are dealing with an XX-DSD. If you have palpable gonads but no Mullerian structure, you are dealing with an XY-DSD. If you have both palpable gonads and Mullerian structures, you are either dealing with an AMH defect or an ovotesticular DSD. And when you have none, no palpable gonads and no Mullerian structures, this could either be an XY-DSD with abdominal gonads, or this could be a case of anarchia, wherein your testes was present at some point of time in utero, whereby it produced AMH leading to Mullerian regression, but by the time it was supposed to start producing testosterone, for some reason the gonad involuted. So that is why the child had atypical genitalia. Common endocrine investigations that are done in children with atypical genitalia, the most common is 17-hydroxylase deficiency, 17-hydroxyprogesterone levels, done when you suspect a case of CH, that is no palpable gonad and presence of Mullerian structures. It is important to note that the levels are done beyond 72 hours of life, and levels greater than 100 nanograms per ml. This level is practically diagnostic of 21-hydroxylase deficiency. It is important to use an extracted sample as there may be interference with other adrenal metabolites in the early neonatal period. Next up is DHEAS. DHEAS helps to differentiate children with XY-DSD when you also have concomitant salt wasting. So it helps differentiate more proximal defects like star and side chain cleavage from 3-beta HSD, which will have a high DHEAS level. Next up is your androstenedione level. Again, important when you have an isolated testosterone biosynthetic defect. So your adrenal and glucocorticoid, mineralocorticoid and glucocorticoid axis are normal. That is when you do androstenedione levels. Like I said, with 17 OHP, you need to do it beyond 72 hours for androstenedione levels, or testosterone DHT levels. Do these levels beyond 7 days. And if you're dealing with a child who is beyond the stage of mini puberty, do HCG stimulated levels. In 17 beta HSD deficiency, you will have accumulation of androstenedione, resulting in testosterone to androstenedione ratio less than 0.8. Next up is your testosterone, helps differentiate between 5-ARD2 and AIS. And last but not the least, next up is dihydrotestosterone levels. Again, testo to DHT ratio greater than 10 will give you a diagnosis of 5-ARD2 deficiency. However, now we know that it is a biochemical diagnosis, and more often we've seen that there is a huge overlap, and genetics is ideally the way to go forward and differentiate 5-ARD2 from androgen insensitivity. Last and most important, I would say, test that is frequently ordered but you need to understand why it needs to be ordered, and when it needs to be ordered is your anti-Müllerian hormone level. So if you have a child with apparent XY-DSD, that is, you have palpable gonads but no Müllerian structure, you don't really need AMH levels. AMH was present at some point of time, and that is what caused Müllerian regression. That suggests that your AMH levels are sufficient. So you don't need to do AMH in every child with XY-DSD. You need AMH when you have presence of Müllerian structure or when you have abdominal gonad and you cannot palpate it. So it will help differentiate XY-DSD due to an intra-abdominal testis from a child who has anorchia. Okay. So yes, again, as I mentioned, if you're dealing with a child who is beyond the period of mini puberty, that is LH is less than 0.7 milli-international units per liter, then you go for an HCG stimulation test. There are various protocols. The one that we follow is take basal sample on day 1, followed by HCG stimulation with 5,000 international units per meter square, followed by a repeat sample on day 4 beyond 72 hours, and testo DHT androstenedione levels taken again at baseline and day 4. In children with XX-DSD, if you have very high 17 OHP levels, high DHEAS and normal DOC, you're dealing with 21 hydroxylase deficiency. If your 17 OHP and DHEAS are both high and your DOC is normal, it could be 3-beta HSD deficiency. Very high DOC is diagnostic of 11 DOC deficiency. And POR, again, you can have variable presentation, but it tends to have high 17 OHP and DHEAS levels. In children with XY-DSD, if all metabolites are low, you're dealing with a proximal defect, star or side chain cleavage. If your DHEAS levels are high, it is either 3-beta HSD, POR deficiency, or 17 hydroxylase deficiency. If your DHEAS and androstenedione both are high, that is 17-beta HSD3 deficiency. If you have high testosterone and low DHT, it is probably 5-ARD2 deficiency. And if you have if your all androgen levels are high, it is likely androgen insensitivity syndrome. So this is the algorithm that you need to follow for stepwise evaluation. And just a minute. Yeah. So if you look at the right side of the screen, I'm sorry, I'm not able to use a pointer here. If you have no palpable gonads and you have presence of Müllerian structure, look for maternal virilization. If you do get a history of maternal virilization during pregnancy, you're dealing with aromatase deficiency. If there is no maternal virilization, look at the 17 OHP levels and your electrolyte status. If you have salt wasting, if you have 17 OHP more than 30 nanomoles per liter, regardless of salt wasting, you're dealing with 21 hydroxylase deficiency. Borderline 17 OHP levels between 10 and 30 with salt wasting could still be 21 hydroxylase deficiency, or it could be 3-beta HSD deficiency. With normal electrolytes, you can have simple virilizing form of 21 hydroxylase deficiency. However, if you have mildly elevated 17 OHP and low potassium, then you're dealing with 11 hydroxylase deficiency. If your 17 OHP levels are less than 10, it is most likely gonadal dysgenesis. Moving on to the leftmost side, if you have palpable gonads as well as Müllerian structures, look for genital asymmetry. If you do see asymmetry, this is over testicular DSD. If not, look at the AMH levels. AMH levels more than 10 are suggestive of AMH resistance, and less than 10 suggest gonadal dysgenesis. Now, everything that lies in between is your XY-DSD or anorchia. So if you have no Müllerian structures, no palpable gonads, do AMH levels. AMH levels less than 10 are practically diagnostic of anorchia, and doing this will help prevent unnecessary diagnostic laparoscopy in the child. If your AMH is more than 10, that means you have viable intra-abdominal testicular tissue. Go for testosterone levels and electrolyte status. If you have salt wasting, it is star side chain cleavage. If you have low potassium, It is 17-hydroxylase deficiency in the presence of low testosterone, of course. And if you have normal electrolytes with low testosterone, it is isolated steroidogenic defect. Now, this could be because of either 17-beta HSD deficiency, LHCG receptor defect, or several other genetic forms. If you have high testosterone with salt wasting, it could either be it is usually 3-beta HSD deficiency. However, in the absence of salt wasting, look for the testosterone to dihydrotestosterone ratio. More than 10 is suggestive of 5-alpha reductase deficiency, and less than 10 is suggestive of androgen insensitivity.
Towards our discussion point, and we are joined by our panelist, and Nimisha is here. So we will be focusing about the various aspects of the cases. Whatever has been discussed will now be discussed in the form of cases. So over to you, Nimisha.
Thank you, sir. Good afternoon, everyone. We'll begin with the first case. 14-day-old preterm girl was brought by the parents with the complaint of ambiguous genitalia. The picture is shown here. Dr. Dhwani, ma'am, what will be your approach in this case?
So, in a preterm child, it is very, common to mislabel someone as atypical genitalia. Preterm children have a poorly developed vulvar fat, which makes their clitoris appear more prominent. So, unless there is some posterior fusion, it may not be wise. Similarly, they may also have edema, local edema, which may lead to a perceived clitoromegaly, which may not be a true clitoromegaly. So, if you don't have any other manifestations, it might best be to wait before we investigate along lines of DSD.
So in this girl, there was no labial fusion, no palpable gonads, and only the labial edema was present. So there was no need for further workup. Your key messages, ma'am?
Yeah, so again, in a preterm girl child, if you have no palpable gonads, if you have, no posterior labial fusion, don't jump to the conclusion of DSD. Give it some time, and it will be more clear whether or not the child needs workup.
Thank you, ma'am. Moving to the next case, 3-month-old girl child with no vaginal opening, no clitoromegaly, and no palpable gonads, with the genitalia picture shown here, was brought to us with ambiguous genitalia complaint. Dr. Varsha, ma'am, your approach in this case?
Yes. Am I audible?
Yes, ma'am.
Okay. Looking at the picture, it is wrongly labeled as DST because under the cover of DST, clitoromegaly is must, or any palpable gonad or AG ratio or more than 0.5, it is must. From the picture, I can realize that it is in some sort of additions. What are the further examination findings?
Yes,
So
ma'am.
it was labial adhesion. It is more common in this infantile age group girls because of low estrogen, in which vulva used to fuse, and because of chronic inflammation, it is more commonly seen scenario. So watchful waiting, if it is asymptomatic, is the key.
Yes, ma'am. So there's no need for further workup in this case. And your key messages for this case, ma'am?
That unnecessary labeling of DST should be avoided. Clitoromegaly and palpable gonads are important to consider if we are suspecting DST, and unnecessary workup should be avoided.
Thank you, ma'am. Moving to the next case, 2-month-old boy was brought to us with a concern for DST. There was penile hypospadia, stretched penile length was 2.8 centimeter, palpable gonads were there. Dr. Prateek, sir, your
Yeah, so
opinion on this?
as Dhwani has rightly explained, what we do need to classify what is DSD and what is not DSD. So if you go by the clinical examination, we have a very distal hypospadia. Yes, stretched penile length is 2.8, which is not less than 2.5, and bilateral gonads are present. So to classify someone as a DSD, you need to have either bilateral undescended testes, or a very severe or very proximal hypospadias, or you have undescended testes with micropenis or hypospadia. So in this situation, to prevent unnecessary investigations, there's no need to workup is just a very distal hypospadias. Yeah.
Very rightly said, sir. Moving to the next case, 8-year-old boy was presented to the OPD with complaint of small phallic size. Height was 130 centimeter. Weight was on the higher side, 44 kg. Bilateral testes were palpable. They were 2 ml in size. Dr. Yasmin, ma'am, your approach to the case?
Good afternoon. Am I audible?
Yes, ma'am, you are audible.
Okay, thank you. Very nice. Actually, if you look at the age of the boy with weight, then the boy having obesity, right? And when we will get a case of a small phallus, then we have to look for the testes. As you can see in this case, no cryptorchidism, rather the testicular volume bilateral 2 ml. So we have to search for the syndromic features also. Then we can go for searching either having, oh, it's not having any polydactyly or any visual problem. Then we have to measure the SPL, stress penile properly. As the boy having his SPL 6 centimeter, then if we know that the age more than 5 years old boy having actually more than 4 centimeter is normal. So no need further workup in this case. So we can consider it's as a case of buried penis in obesity.
Yes, ma'am. There was no need for workup and it was a buried penis. Moving to the next case, day 3 child who was brought to us with a concern regarding ambiguous genitalia. It was Prader 4 stage with no gonads. Dr. Dhwani, ma'am, how would you like to approach this case?
Yeah, so again, if you have no palpable gonads, either examine or go for an ultrasound for Mullerian structures. So were the Mullerian structure present or not?
The Mullerian structures were present.
We're dealing with an XX DSD. The next step in this algorithm would be to look at the electrolytes and 17 OHP levels.
Yes, ma'am. So uterus was present and karyotype was done. It was 46XX. There was hyponatremia along with hyperkalemia.
So again, as we can see, hyponatremia, hyperkalemia, and 17 OHP more than 100 nanograms per ml, practically diagnostic of 21 hydroxylase deficiency, the most common form of DSD we encounter in our day-to-day office practice actually.
Yes, ma'am. So the gender of rearing according to you?
Yeah, so again, a very controversial subject, but yes, if you had a lower Prader staging, we would probably counsel the parents more along lines of a female gender of rearing, but with such such degree of virilization, a male gender of rearing would probably be more fitted to the child. But again, it is something we would want to discuss with the family and take the child's opinion into consideration as they grow up. And that is how we will be going ahead with the gender of rearing, decision of gender of rearing in this child.
Okay, thank you, ma'am. So this was the case of CAH. The key messages here, ma'am.
So if you have bilateral cryptorchidism in an apparent male, look for, this is again, you work up along lines of DSD, look for presence of Mullerian structures. Timely evaluation in these children is life-saving. With proper treatment, they can lead a normal life. So do pick up them in your OPD as soon as you see these patients. When you're going for 17 OHP levels, do them beyond day 3 of life.
Thank you.
So, Dhwani, when would you like to go for clitoroplasty in this case? And what would be your
Clitoroplasty, yeah, so clitoroplasty could be done early, before starting school actually, if the parents are willing. And vaginoplasty could be done later on in life,
Yeah.
by the time they're nearing their menstruation.
There are a lot of legal and ethical issues also which have now cropped in. So we need to be very cautious in that regards. And now many states have actually got policies that unless and until you have a proper institutional review board, you don't go ahead with that. So this is becoming very difficult. But this is one scenario where there is no issue as far as the gender of rearing is concerned. We are very clear that it should be a female gender of rearing. But yet we have to adhere to the local guidelines, and hopefully there will be newer guidelines coming up for DSD which will tell us exactly how to approach overall, because many pediatric surgeons are now really not ready to do these cases easily. So that is something which is very important to address.
Thank you, ma'am. Moving to the next case, day 3, child was brought with the concern of DSC. The picture is shown on the right side. With Prader 4 staging, there was no gonads were palpable. Dr. Varsha ma'am, how will you like to approach this case?
Okay, no gonad. So no gonad, it means either we are dealing with XX-DST or XY-DST with abdominal gonads. I would like to know about the Mullerian structures. Were the Mullerian structure present in this child or not? Uterus and
Ma'am, Mullerian structure was present. Uterus.
oh, okay. And karyotype is 46XX. So either with this scenario, either we are dealing with 21 hydroxylase deficiency or other rare form of CH like 3 beta or POR deficiency, aromatase. I would like to know the history of maternal virilization. Okay, so there was maternal virilization present. So most likely we are dealing with the case of aromatase deficiency as the 17 OHP is less than 30, which is also one of the conclusive of the rare variant, and maternal virilization is a great clue for POR or aromatase deficiency.
Very rightly said, ma'am. Borderline elevated 17 OHP raised the possibility of aromatase deficiency. The gender of rearing, according to you, ma'am?
Gender of rearing, it is again controversial, but social, psychological, legal, ethical issues come into the play. But within the 46XX-DSE, with this, usually the sex of rearing which should be offered with the consensus would be the female gender of rearing.
I think that's a very, very valid point, and the main determinant as far as gender of rearing is particularly the psychosocial sexual orientation is how much androgen was exposed in the given period. So if the androgen is very, very high, let's say bladder stage 4 or 5 of CAH, or some cases, that is the only scenario where you will find gender dysphoria. Usually with aromatase deficiency, you will have a normal female, and this was a child actually who came to us very late. This was one child who came early, but one child came late, diagnosed as CH, managed with the steroids, and then when we saw it was not fitting into CH, then we evaluated and found there was aromatase deficiency. But the big problem there would be that they will have no estrogen production. So they will have again some virilization and puberty, and they will go into premature ovarian insufficiency. So that is a bit of a issue there. Fertility will be an issue.
Thank you, sir. Moving to the next case, day 14 child was brought again with the concern of DST. Bilateral gonads were palpable here. There was no uterus. The karyotype was done. It was 46XY. Dr. Prateek, sir, your approach to the case?
Yes, absolutely. So, as opposed to the case we saw previously that I discussed, we clearly have a DSD over here now. We have a phallic structure, we have bilateral gonads present, and ultrasound, and we have XY and no Mullerian structure. So, we are dealing with XY DSD. So, this is an undervirilized male, and there has to be a defect in testosterone production. So, if you go back to the previous slide, in this, yeah. So basically it depends on, we can either have a very proximal defect or a very distal defect. And based on biochemistry, it is easy to know, because as and when you go down the steroidogenic pathway, the metabolites will keep accumulating. So you'll have lower metabolites in a very proximal defect such as STAR or SCC. And as and when you go down to AIS, you will have everything being high. So that is a very good indicator of where we lie in the steroidogenic pathway. Now, after this, if we follow this pathway, if we have palpable gonads, if we have Mullerian structures, here we had no Mullerian structures, we have an XY-DSD. So we look for testosterone levels. Testosterone levels were low. Is there any salt wasting? So we do have salt wasting. We have hyponatremia, hyperkalemia, 17 OHP is high. So we do get salt wasting scenarios over here, STAR, POR, 3 beta HSD. A good test in this situation would be DHES levels to see whether it is raised or low. And in this situation, can we go to the next slide then? What came out of it? So yeah, DHES levels would have been high in this situation. And then again, the question of gender of hearing it's not something that we can just pinpoint and say at the moment. It requires pediatric endocrinology, urology, psychology support, and it's of course parental discussion at that point. So again, considering all of that, we need to think of gender of rearing rather than a stat discussion like that. Yeah.
In that you have got peripheral conversion to testosterone, so you will have some testosterone which is there. It's not good enough to cause virilization in a boy, but it's good enough to cause virilization in a girl. So generally, Dr. Pratik, we talk about when we say you have a XY-TH, we generally say, okay, you go for a female gender of feeding, but 3-beta HSD could be a complicated,
Yeah.
with your androgen levels may be reasonably high from that
Yeah.
perspective. The other thing I wanted to discuss with you is about the DHEAS level. So we do see the DHEAS levels are usually very high in most infants because of the effect of the fetal adrenal being there and more starvation happening. So what do you think would be the assessment? Because we have seen many cases of 5-alpha reductase and partial AIs who have a high DHEAS. So what is the major role of DHEAS here?
So I can't hear. Yeah. So
What is the major role of DHEAS here, do you think, in the setting?
So it's basically to know if it's an adrenal production of testosterone, and then that if there's a block there, we can get high levels of that.
So I would say that from my perspective, low DHEAS is more important. If your DHEAS is low, you have a very proximal defect.
Yeah, yeah.
Have a high DHEAS, it may be non-conclusive.
Yes.
Then 17 OHPs and other things become normal and important from that regards. But this is a very valid point about gender of favoring.
Thank you, sir. So, gonads with no uterus, suggestive of XY-DSD, and in this case, salt wasting along with high 17-OHP was suggestive of 3-beta-HSD defect. Moving to the next case, 14-day-old child was brought with the concern of DSD. Here, the picture is shown. There was asymmetrical genitalia with right side testis was present, and on doing ultrasound, uterus was present. Dr. Yasmin, ma'am, your approach to the case?
Thank you. It's a very nice case. You can see there is a asymmetrical genitalia, and we have to search for the Mullerian structure clinically or by doing simple ultrasound, pelvic ultrasound showing here uterus is absent. Then we can consider it's a case of ovotesticular DSD. So we should also advise for a karyotype, and you can say that in this case, you can ensure that is fit-free metaphase plates accuracy and rules out the mosaicism, and also we can advise for a fish also for a rapid test to quicker preliminary confirmation of chromosome before getting the reports of that sex chromatid abnormalities. If you look at the flow chart, you can see that when we will get a case of palpable gonad, then as we have to look for the Mullerian structure. If you compare with the previous case, you can see that the difference between here is that the presence of Mullerian structure, then we have to look for the AMH also. If it is low, then we can consider it's a case of either anarchia or dysgenesis. If it is high, then we can consider it's a case of AMH resistance. Then in this case, it's completely is a case of ovotesticular DSD.
Thank you, ma'am. Your key messages, ma'am?
Key message is that when you will get a gonad with uterus, then we have to consider it's a case of ovotesticular DSD. And that means when you will get asymmetrical genitalia, either XX or XY DSD should be in your consideration.
I think ovotesticular DSD is a very, very complicated scenario where a lot of issues are there. One issue which we want to maybe discuss is when should we consider gonadectomy in these settings, Dr. Yasmin?
Yeah, in this case, when we'll think about because there is chance of malignancy is more, that's why as we should advise and sex before that we have to think about the sex rearing also, and then we can advise the patient for the gonadectomy.
So definitely white present is a very, very clear-cut marker that you have to worry about that. And except for, let's say, androgen insensitivity where the testosterone is not in the biosensitive effects are okay, but if you have a dysgenesis, removing that becomes very, very important. Very nicely pointed out by Dr. Yasmin.
Thank you, ma'am. Moving to the next case, 15-year-old girl presented with the complaint of delayed puberty. On examining, there was inguinal gonads. There was no Mullerian structures. And Dr. Dhwani, ma'am, what will be your approach to the case?
So, like I pointed out earlier, if you have a girl with delayed puberty, primary amenorrhea, do have a suspicion for this being a DSD. And when you do your sexual maturity rating, or when you examine for your breast and pubic hair, do palpate for presence of inguinal gonads, as was done very rightly in this child. So you had a girl, 15-year-old girl with delayed puberty with presence of gonad and no Mullerian structure. So we're dealing with an XY DSD. Again, I want to know the electrolyte and androgen levels here.
So, ma'am, there was potassium was 3.2, and there was hypertension present in the child, and testosterone levels were low.
Again, classical of 17 hydroxylase deficiency. So do measure BP. And FSH levels again 120 say that your Sertoli cell function is gone and the child may never be able to have a biological uh, offspring. But yeah, your diagnosis here is 17 OHD deficiency.
Your key messages, ma'am?
So consider DSD in a child with primary amenorrhea, regardless of whether or not you have breast development. Monitor BP. It could, if you have hypertension, it could either be Turner or you can have 17 hydroxylase deficiency. So in a child with primary amenorrhea, always measure your BP. Look for, palpate for inguinal labial gonads.
Well, in this regard, often the hypertension will improve once you give steroids. If it's persisting, what would be your treatment of choice? You will just call Dr. Gani here. The hypertension, if it is persisting,
you will need to give. I'm sorry.
blockers like
Yes.
that will be there.
Thank you, ma'am. 12-year-old boy presented with the complaint of hematuria. On examining, there were no gonads palpable. Dr. Varsha, ma'am, how will you approach this case?
Okay. So, with no palpable gonade, actually, most of the time, DSTs, it is thought that it's always in the infantile, but late onset, if boy having hematuria or girl with primary amenorrhea, they should also be thought for the DST. So, no gonades. I would like to know about the Mullerian structures.
Mullerian structure was present, ma'am.
Okay. Karyotyping?
46XX.
Okay, so with this all scenario, either we are dealing with CH variants like 11 hydroxylase. I would like to know about the potassium and DOC levels of the child.
Potassium was on the lower side and there was hypertension along with it. And DOC
Okay, so with the huge virilization and later on said this hematuria, which is actually the menstrual blood that is coming in the form of urine. So it seems to be the case of 11 hydroxylase deficiency.
very rightly said, ma'am.
Okay.
Gender of rearing in this case, ma'am?
Gender of rearing at this stage, again, it's very controversial, but with this is at this stage, 12-year of child always being reared as a boy, social and psychological factors come into the play. Most of the time, with all the keeping in view multidisciplinary approach, keeping all in the loop, psychologists, everything. Most of the cases at this stage are reared as boy because chopping off such huge penis is also not possible at this stage. But again, all the factors come in the play.
Your key messages with this.
Yes, my key messages are that DST is always not in the infantile age group. Later onset, phenotypically female with primary amenorrhea. Think about DST. Phenotypically male with hematuria, which could be the menstrual blood. Think of the DST. And XX DST with hypertension is 11 hydroxylase.
Thank you, ma'am. So XX DSD with hypertension is 11 hydroxylase and XY DSD with hypertension makes the diagnosis of 17 hydroxylase deficiency.
17, exactly.
Moving to the next case, 15-year-old girl presented to the OPD with complaint of primary amenorrhea. Height was 154 centimeter, weight was 48 kg. Breast stage was 4, pubic hair was stage 2, inguinal gonads were palpable here. Dr. Prateek, sir, your approach to the case?
Yes, thank you. So we have a 15-year-old girl who's of average height, average weight, who's had breast development, pubic hair development, and there's gonads being palpable. So now if we go by, let's evaluate further. First, we get an ultrasound done, and the ultrasound shows an absent uterus. Next step, karyotype is showing XY. So at some point, we have AMH, which has worked, and we have testosterone, which is not working. So what we find is then when we do the testosterone, it is very high. So at a point, we have testosterone, which is the bodies which is resistant to testosterone, and the diagnosis is pretty clear cut from here. We have an insensitivity to testosterone. The testosterone to DHT ratio less than 10 means that it is being converted to DHT. So the receptors are not working, suggestive of a complete AIS. Yeah.
Thank you,
So
sir.
in this situation, again, gender of rearing, here it is quite clear cut. The girl has been raised as a girl. We don't have to consider the gender, but we need to have a very clear-cut discussion with the girl about fertility and further issues, which is very important in this situation.
Thank you.
Also, to complete AI, just because the androgens were not working, they will not have an issue in terms of the visualization in the antenatal period. So better to go ahead with a female gender feeding. The main question would be, when should we do a gonadectomy, doctor?
In this situation, so again, it is quite controversial. Again, the pros, there's discussion about, consideration of gonadectomy, considering the risk of malignancy, but there's been situations where individuals have wanted to, because of the aromatization, they have wanted to keep the gonads. So again, it is a discussion to be held.
So the key messages in this case was primary amenorrhea with pubarchy and breast stage development of 3 or 4 is suggestive of AIS, and they feminize during puberty. Moving to the next case, a 10-year-old girl with clitoral enlargement, phallic length was 2.2 centimeter, bilateral gonads were palpable. Dr. Yasmin ma'am, how will you approach this case?
Thank you. Again, there's a very nice case that's with bilateral gonads with phallic length. Then we have to again look for the Mullerian structure of in this case also. As you can see in the flowchart, there the girl having no uterus. So, and the karyotype is 46XY. Then we have to go for the testosterone level.
The testosterone.
Oh, testosterone level, as it's a high, then we can consider for the dihydrotestosterone level. As it's showing that's low, then we can consider it's a case of 5-alpha reductase deficiency.
The gender of rearing.
So in this case, as the patients will get in puberty, the virilization will develop, then it can be considered this case as a case of male, as a sex rearing.
So in this case, because the issue is not action of testosterone, it is a conversion to DHT. Usually in the antenatal period, the DHT would have been very high. And they will have very high testosterone DHT during the testosterone at the level of the mini puberty. So they will virilize from that perspective. So this is something in which male gender feeding is often what is recommended.
Thank you, ma'am.
So I think I'd like to thank Dr. Nimisha for really going through this wonderful discussion. And I'll now just request Bhani to tell us a bit about the DSD interpreter, which we have developed and how it works on that. Because a lot of us, when we talk about these lectures, it becomes easy. But when you really see a patient, it often becomes very difficult to interpret it. And if you look at the algorithm, which is here, most people will stop thinking once they see the algorithm and they go forward from there. So Dhwani, what exactly did we do and what did we find in that regards?
Thank you so much, sir. So what we have done here is taken a sequential evaluation wherein you look into the clinical parameters and key lab investigation, that is your electrolytes and basic hormonal levels, and do it stepwise so that you don't run a huge battery of tests for the patient. So that is how, let me show you and our application has shown a concordance that is at par with the experts and is expected to truly help out pediatricians, neonatologists, and pediatric trainee when dealing with children with atypical genitalia. So this is our MediClasses app wherein we have the DST interpreter. It says if you have palpable gonad, yes, no Mullerian structures. It prompts you to enter the electrolyte and testosterone value. So you can see that here you have salt wasting and it gives you a diagnosis. It gives you the diagnosis. It asks you what to do next. So consider karyotype and genetic study and follow-up approach to be done next. If you have no palpable gonads and Mullerian structure, then you're dealing with an XX DSD. It asks for maternal virilization. It asks you for the 17 OHP and electrolyte levels. And what it does here is it analyzes. It tells you this is likely salt wasting, adrenal insufficiency. Start your steroids. Consider a female gender of rearing and monitor 17 OHP levels and electrolytes. So not only does it give you a diagnosis, it tells you what treatment needs to be started and what needs to be monitored and follow up. It also gives a guidance on the gender of rearing, which is again not hard and fast, but something to be considered. Last up, we have a child with, let us see what input start here. Palpable gonads as well as Mullerian structures. So it asks for your genital symmetry and AMH levels, based on which it makes the diagnosis of ovotesticular DSD. Now it tells you what kind of karyotype needs to be done. So it says 50 metaphase karyotype and go for a genetic study preferably.
And this interpreter, the main feature that we have tried to develop is to do a sequential approach in terms of workup and not all the workup at a time. So even with XY-DSD, we're not telling you to do testo, DHT and all the investigation in one go. You go step by step. So this will provide us a cost-effective way of evaluation in that regards. So before we move ahead with the next session, we'll see if there are any particular questions which are there. From that perspective, there are any questions for the DSD session? I think there are none, and I'll invite all of you who are attending the session to please post their queries, as in when they have any this thing, we'll answer it at the end of the session. So I'll really thank Dr. Dhwani, Dr. Prateek, Dr. Yasmin and Dr. Varsha for joining the session and covering this complicated topic within 50 minutes. So this was a session which has gone before time, and Dr. Nimisha has been also being part of the expediting the session very quickly. So that's good that we are able to cover this topic and hopefully will be of help in that regard. So we'll now move forward to the next session. And the next session is about an important aspect of electrolyte disorder. So Dr. Neha will be talking about electrolyte disorders. Before we hand over to Dr. Neha, we'll quickly introduce the participants of this session. So in this session, we have Dr. Neha Agarwal, who is our first fellow, along with Dr. Chetan, who was there last week. Yesterday, who was there. She is currently working as a pediatric endocrinologist, Regency Lucknow. She got her training from GSPM, then BHU, and then from here, and then international training, and has multiple publications from that perspective. We are pleased and honored to have Dr. Mahesh Kore, who is a very senior pediatrician who has been working in Nipani region in Belagavi district of Karnataka and has been able to identify many complicated cases there. In that perspective, we have got Dr. Amit Kumar, who is additional professor of pediatrics at Indira Gandhi Institute of Medical Sciences, Patna. We have got Dr. Varuna Vyas, who is associate professor of pediatrics at AIIMS Jodhpur. And we've got Dr. Sangeeta Ras, who is from Department of Pediatrics, AIIMS Nagpur, and has been associated with us from that perspective. So we will hand over to Neha. Neha, you can start the presentation from your end.
Good evening, sir. At the outset, I would like to thank Mediclasses, Dr. Anurag sir, for inviting me for this session. So I start sharing my slide.
Yeah.
So is it visible, sir?
Yes, it's visible. Yeah, please go
Okay.
ahead.
So when we talk about electrolyte homeostasis, we are basically dealing with two things. One is tonicity, which is under the regulation of sodium ion, and the second is volume, which is determined by the water status in our body, which in turn is regulated by two mechanisms: the thirst, that is amount of water that we are taking, and urine output, the amount of water that we are utilizing and then excreting out of our body. So when we talk about tonicity, it is basically regulated by sodium, and whenever there is an increase in tonicity, it is sensed by the osmoreceptors in the brain, which causes production of the AVP hormone or the antidiuresis hormone, which decreases the urine output and thereby decrease the tonicity in the blood. On the other hand, whenever there is a decrease in the volume status of the body, there is a secretion of the activation of the RAS axis, which causes sodium retention and potassium excretion, and hence in defects involving the RAS axis, we find hyponatremia and hyperkalemia. In long-standing cases of RAS defect, because of this excess volume which is generated by sodium absorption, there is activation of the atrial natriuretic peptide, which causes natriuresis, and hence we do not find any sodium imbalance but hypokalemia and alkalosis in these long-standing RAS defect axes. So potassium is not only regulated by the RAS axis, but it is a major intracellular ion and hence is also influenced by other factors such as insulin, beta agonist, alpha receptors. Moving on to serum sodium. Talking about the timing of the day, when should ideally be serum sodium done? So it can be done at any time of the day. Few caution that we need to keep in mind is we should avoid taking the sample after strenuous exercise and in particular after seizure where we can find falsely high sodium values. False values can also be found in cases of hyperglycemia, hyperlipidemia, hyperproteinemia, where it can be pseudo-hyponatremia, and high false sodium values can be seen in cases of hypoalbuminemia. So normal range of serum sodium is somewhere between 135 to 145. Less than 130, we declare it as hyponatremia, and any level more than 150, we treat it as hypernatremia. Similarly, for serum potassium, it can be done at any time of the day with certain caution in mind. Avoid hemolysis, avoid using syringe for sampling, and no tourniquet, especially in long-standing sample should be avoided because of hemolysis of RBCs that can take place and we can get high false potassium values. Falsely high values can come in terms of hemolysis and if the sample has high TLC count such as leukemias where excess of potassium is utilized and falsely low potassium can be seen. Also in blood gas analyzers, we get falsely low potassium by 0.4 millimoles per liter in comparison to serum potassium. So serum potassium can be affected by tourniquet, squeeze sample, and high cell point. So these three things should be kept in mind while sampling the potassium. So sodium and potassium, when taken together, gives us a better picture rather when we analyze sodium and potassium independently. So we should try analyzing the two ions together. Let's see how. So if there is a high sodium with low potassium, we are dealing with RAS axis. If there is low sodium with high potassium, we are dealing with RAS defect. If there is high sodium with high potassium, one condition is Gordon syndrome, and both sodium and potassium are low in cases of Bartter and Gentleman syndrome. So hyponatremia is basically or predominantly caused by excess of free water in conditions such as overload seen in cardiac cases, liver cases, renal cases, or when there is a reduced loss seen in cases of hypothyroidism, cortisol deficiency. And after ruling out that cortisol and thyroid levels are normal, then SIADH can be diagnosed. Sodium loss can either be renal or extrarenal. Extrarenal, we get urine sodium less than 25, such as diarrhea. In renal cases, it can either be tubular causes or aldosterone defects, such as RAS defects, pseudohypoaldosteronism, in which urine sodium will be more than 25. So whenever we are dealing with a case of hyponatremia, always look at the volume status of the patient. So these are the four things we need to analyze to get a diagnosis of hyponatremia or the cause of hyponatremia. First, uric acid. So uric acid will be low in cases of hypervolemia such as fluid overload, cardiac, liver, renal causes or SIADH. Urine sodium will be low in cases of fluid overload and extrarenal causes, whereas renal, tubular, diuretic or SIADH will have high urine sodium. Similarly, by assessing or looking at the potassium and hemoglobin, we can streamline the causes of hyponatremia. So moving on to the approach, how to approach to a case of hyponatremia. First thing, rule out the causes which can cause a falsely high or low serum sodium level. Check for blood sugar, lipids, and protein. Second step, analyze the fluid status of the patient. So as already discussed, fluid overload cases will have hypervolemia, low uric acid levels, low urine sodium levels. So these can be due to cardiac, liver, renal causes. Euvolemic patient, first rule out thyroid, cortisol. After ruling out these two, we can diagnose for SIADH. Hypovolemia can happen in cases of renal loss or extrarenal loss. In case it is a GI loss, then renal loss will be less than 30 millimoles per liter. For renal loss, urine sodium will be more than 25 or 30 millimoles per liter, then check for potassium. In cases of tubulopathy or diuretic, potassium will be low, whereas in cases involving the aldosterone axis, potassium will be high. So rule out the potential defaulters such as lipid, protein, sugar, check for the fluid status, then analyze the urine sodium and serum potassium. So these factors will help us categorize the cause of hyponatremia. So using certain cases, now we can help ascertain the approach. So are we discussing the cases after this?
Yes, probably.
Sir, you're mute.
We'll start with hyponatremia cases and then we will use this common presentation because other things are the smaller slides, I think.
Okay.
So start with the first case and I'd like to invite Dr. Ria to start off the case.
Thank you, sir. Good afternoon, everyone. Starting with cases. Case number 1, a 12-year-old boy diagnosed with diabetic ketoacidosis had blood sugar of 700 milligram per deciliter. Sodium was low, 126 millimole, and potassium was 3.6. pH was 7.1. So I would like to ask Dr. Varuna ma'am to approach this case.
Good evening, everyone. So from this case, we can clearly see that the blood sugar is elevated and the pH is low. So there is a strong possibility this child is in diabetic ketoacidosis. So whenever the blood sugar is raised, there can be a falsely low sodium value as well as there can be, because of the dyslipidemia that may be there with the diabetic ketoacidosis, that can also add to a falsely low sodium. So I would first like to correct the sodium and also I'll continue with the management of the diabetic ketoacidosis.
So the corrected sodium was done and the corrected sodium was 135.6 according to the formula. So what would be the key messages, ma'am?
So the key messages are that whenever we have patients with the diabetic ketoacidosis or very high sugar levels, there is a possibility that we can get falsely low sodium value. So, and there are also other conditions where we can get falsely low sodium values like hypoalbuminemia, dyslipidemia. So always check for those factors before we assume that the patient is hyponatremic and correct for the respective metabolite.
Thank you, ma'am. Case number 2, 1-week-old boy came with the sodium of 128 millimole per liter and potassium of 3.6 millimole per liter. So I would like Dr. Sangeeta ma'am to approach this case.
Am I audible?
Yes, ma'am.
Okay. Good evening, everyone. Thank you. Thank you, Dr. Ria. That's an interesting scenario with a 1-week-old boy with hyponatremia. So here we have to see some pointers like what is the fluid status? In this case, is there any signs of hypervolemia or dehydration?
No, ma'am, there was no dehydration. A patient was euvolemic.
So 1-week-old boy, we are dealing with euvolemic hyponatremia. And as we can see, there are some pointers like with the boy has hypoglycemia, ketotic hypoglycemia, and also micropenis. So this is an interesting scenario which usually points to an endocrine deficiency. In this scenario, it will be multiple pituitary hormone deficiency, where we have to do the cortisol levels. And as we can see, the cortisol is 125 nanomole per liter and growth hormone is 4 nanogram per ml. So if we correlate it with the blood sugar and hyponatremia, these are inappropriately normal. So inappropriately normal in this scenario, it points towards that endocrine deficiency, that is multiple pituitary hormone deficiency. So this is a case of hypopituitarism. So the key messages here will be in a case of euvolemic hyponatremia, we always have to first see the cortisol level and we have to rule out the endocrine causes before reaching in a diagnosis of SIDH. And cortisol level below 550 nanomole in case of hyponatremia is significant. It's a low. It points to cortisol deficiency.
Yes, thank you, ma'am. Case number 3, a 14-year-old boy came with drowsiness and hyponatremia and sodium was 116 millimole per liter. He was euvolemic, urinary sodium was 100 millimole per liter and urine osmolality was 300 milliosmol per kg. He was diagnosed with SIADH and fluid restriction was done. So do you agree with this diagnosis, sir? Dr. Mahesh, sir?
Yeah. Thank you. This was a 14 years boy and he had a drowsiness drowsiness may be because of his hyponatremia. And he has clearly said that he is euvolemic. So, like previous case, we have to rule out something, hormonal things, before labeling it SIADH. So we have to look for cortisol and hypothyroidism, because these are the two mimics of SIADH. In our case, there is hyponatremia, urine sodium should be low or it should be preserved by that. And urine osmolality should be, the body should try to lose water, because hyponatremia is because of excess of free water. It was not done in this case. That's why it was called as SIDH. But mimickers of SIDH are uh, cortisol deficiency and hypothyroidism. As you have seen here, the free T4 is low, that is less than 10. Uh, it is 2 only, and cortisol inappropriately normal. It should be more than 550. So both the conditions are low. So it points towards the multiple pituitary hormone deficiency.
Yes. What are the key messages in this case, sir?
Yeah. SI is a diagnosis of exclusion, means it is a primary or secondary. Secondary can be a hormonal like hypothyroidism, or cortisol can mimic SIDH like euvolemic. Though we have to label SIDH, we have to rule out these two conditions. Otherwise, it will be treated falsely as SIDH with water restriction, and they will not be. We have to treat cortisol and we have to treat hypothyroidism. Then only this boy will be normal.
Thank you, sir. So moving to case
Thank
number
you.
4. 4-week-old child came with failure to thrive and hyponatremia. Sodium was 110 millimole per liter. Birth weight was 2500 gram, and now it is only 2600 gram. He was dehydrated with high hematocrit. PCV was 62. Urine sodium was 100 millimole per liter, and potassium was very high, 8.4 millimole per liter. So I would like to ask Dr. Amit sir to approach this case.
Thank you, Anurag sir, for this opportunity, and Dr. Ria for the case. So what we have a 3-week-old child, not gaining weight, actually gained only 100 grams. And as you already have told, that the patient is dehydrated, because PCV is again a good marker of dehydration. It's increased. Urine sodium is again high, as told. It is 100. If it's more than, so coming to this algorithm, what we can see that fluid status, as already discussed, the patient is hypovolemic, urine sodium is on the higher side, and as already told, potassium is also very high. So the thing which first should come out, to our mind is RAST effect. And as we can see in the figure, there's definitely, was there a typical genitalia?
Yes, sir. There was atypical genitalia.
Yeah, okay. So definitely it seems to be, and the 17-OHP as shown is very high. So it seems to be a case of classical CH caused by 21 hydroxylase deficiency. Yeah.
So what are the key messages, sir?
So, as it's a norm that a patient with hyponatremia, hyperkalemia, and dehydration, definitely we should suspect RAS effect as our first GD. And if there is atypical genitalia, the diagnosis of CH is almost confirmed. And in males, actually, we should be very much cautious, because they don't have that much of atypical genitalia, and what they present with is shock and can die actually.
So once they come to you, suppose the child has come to you, Dr. Amit, how will you
Yes.
manage him in the initial phase?
So initial phase, definitely it should be fluid, hydration should be there, and we can start hydrocortisone intravenous, sir.
And what will be your targets of sodium rise in this scenario?
So the targets should be, sir, like we have to, we should try to go for, sir, it should not be very high, sir, because, but we have to go for fast, sir, like, because it's 10 should be, we should increase by 10, sir, at least, so yeah.
So this is an acute hypernatremia.
Yes,
It
sir.
will not be much CNS adaptation. So
Yes,
these
sir. Yes, sir.
we can be more quicker
Yes,
in
sir.
replacement. The previous case which Dr. Mahesh was discussing was more of a chronic hyponatremia.
Yes,
Now,
sir.
even if it is SIADH or if it is MPHD, we should not be too aggressive, because
Yes, sir.
otherwise there will be a lot of changes in the osmolality and osmotic disequilibrium can come in on that perspective. So generally for chronic, we say around 6 millimoles per liter per day, and acute you can go up to 12, but CAH I have seen they can go very rapidly and they will be fine also, and there will not be much of a problem in that regard.
Yes.
Thank you, sir. Coming to case number 5, a 6-month-old girl child with cystic fibrosis had failure to thrive and recurrent chest infection. Her sweat chloride was 120. There was no steatorrhea, and there was hyponatremia of 120 millimole per liter, and potassium was 6.8 millimole per liter. So I would like to ask Dr. Varuna ma'am to approach this case.
So clearly this patient has hyponatremia and hyperkalemia. While hyponatremia might be there because of cystic fibrosis and chest infections can be there because of cystic fibrosis, the other features don't really match. That patient is having hyperkalemia and also that there is no steatorrhea. So for a hyponatremic patient, I would really want to assess the volume status of the patient.
So ma'am, she was dehydrated.
Okay, so patient was hypovolemic. And how was and if the patient is having significant urine sodium loss, so we assume that patient is also not having GI loss, then there is a possibility that this patient may be in having a condition where there is a poor response of the renin, angiotensin, aldosterone axis. So we should always consider a possibility of a pseudo hypoaldosteronism in such patients, and they also tend to present with hyponatremia and hyperkalemia with chest infections. So small child failure to thrive, definitely pseudo hypoaldosteronism should be considered as a possibility.
Yes, ma'am.
So, Dr. Varuna, how would you like to manage this case?
Sir, in this case, we can give a trial of high dose of mineralocorticoids and see if there is any response. And of course, we have to provide supportive care for the pneumonias. And also, we should do a genetic test to confirm the diagnosis of pseudo hypoaldosteronism type 1.
These are very, very difficult cases to treat
Yes,
actually.
sir.
And as you said, we have to try, we have used up to 5 to 6 tablets also of Floricort, and they tend to respond because it's not an absolute resistance. You have to give a lot of salt, sometimes bicarbonate also. So we had giving sodium chloride along with bicarbonate, and avoidance of potassium, because the potassium is the major cause of concern. So when you have these sort of scenarios, you will more have hyperkalemia rather than hyponatremia will not dominate. While in CAH, hyponatremia will be so severe and then hyperkalemia will be secondary. So this is a very, very difficult situation. But once they go about 1 to 2 years, they get a lot of salt themselves, they are better off. And as Dr. Varuna said, because of the inspissated secretion, they will have a lot of pneumonia. Then if they have minor infections also, that can be lethal. So we have to be very cautious in that scenario. Very well pointed out.
Dr. Anu, can I ask something?
Yes, Dr. Mahesh.
Yeah, we had a case of pseudo hypoaldosteronism, but it was very difficult to manage. We have gone up to 5 or 6 tablets of Fluricort and salt supplementation. He had a very strong, bad infection, and we could not survive that child. It was genetically proved pseudo hypoaldosteronism, but we could not survive beyond 1.5 months. We have tried our level best, but child could not be saved. What are the other ways to treat this child? Any other way or anything, something else can be done for this child?
So the management options are limited. One is that you can use higher doses of fluorocord, which you're anyway doing. Sometimes they may need to be admitted for sometimes to tide over the crisis, give them fluids repeatedly. Some medications, some people talk about the roles of possibly steroids as an option. Some talk about carbenoxolone, which is an inhibitor of 11 beta HSG2. So that will typically be allowing that you will now have more action of glucocorticoid on the mineralocorticoid receptor. So it's the other way around. It's like working the other way around.
You manipulate that. Okay.
So that is there, but it is a difficult condition, and we have been managing a couple of cases largely with very high doses of fluorocord. And I agree, first year is the most difficult. Once they cross 1 year, it becomes much, much easier. But the biggest cause of death is not hyperkalemia if you're managing them properly. It is the chest infection. So minor infections also can become a big problem.
Yeah.
You have to start maybe steam nebulization. So everything we start right away so that the secretions don't get stuck. That is the biggest.
Yeah. Our child has potassium around about 9.5, or he went up to 11, but he didn't have any arrhythmias because of that 11.
They are tolerant to that.
Tolerant to that because it is a chronic disease. They are adapted to that.
Yeah, so we always obviously give potassium, K bind, and all those things as well.
Yeah, we tried all our best, but we could not save that child.
So it's a difficult condition.
Difficult condition, yeah. Okay.
Thank you, sir. Moving to case number 6, 1-month-old boy came with reduced feeding. His birth weight was 3100 gram. Now it was 3200 gram. Sodium was 124 millimole per liter and potassium was 6.8 millimole per liter. 17 OHP was done, which was 5 nanogram per ml, and the cortisol was 1200. Plasma renin activity was 12 nanogram per ml per hour, and aldosterone was 200 nanogram per deciliter. So I would like to ask Dr. Sangeeta ma'am to approach this case. Dr. Sangeeta ma'am?
Sorry, yeah. So if we see the history here, 1-month-old boy with reduced feeding, and there is a failure to thrive scenario out here with hyponatremia. So that means we are dealing here with hypovolemic hyponatremia status, and with potassium of 6.8 millimole per liter, that is hyperkalemia. So what we are dealing here is a case of RAS defect. So in this scenario with 1-month-old boy, we should always rule out steroidogenic defect like congenital adrenal hyperplasia. But there is no history of any atypical genitalia, and 17 OHP level and cortisol levels, they rule out that steroidogenic defect. And on the other hand, that PRA value of 12 nanogram per ml per hour and aldosterone of 200 nanogram per deciliter, that means these values are high in a case of hypovolemic hyponatremia with hyperkalemia. So it points towards aldosterone resistance. So we are dealing here with pseudo hypoaldosteronism. But before we know the genetic causes, before that we have to always rule out the transient causes like UTI, urinary tract obstruction. And as we can see here, urine RM is more than 100
More than
WBCs, and
100
USG
WBCs
suggests,
per pound. Yes.
yeah, and USG is suggestive of obstruction. So that means we are dealing here with transient pseudo hypoaldosteronism. So that if we can treat the infection judiciously, so the condition can be reversible. That's a good thing. So the key message here will be consider transient pseudo hypoaldosteronism with the infection before moving to genetic causes, and it usually reverses with treatment.
Thank you, ma'am.
So I'll now ask Dr. Neha to quickly go through the hypernatremia overview.
So talking about hypernatremia, this is the other aspect of sodium imbalance. So it can either be caused due to reduced free water or an actual increase in sodium load. So reduced free water can happen due to reduced intake in cases such as neonate or morbid patients who are dependent on others for the water intake, adipsia, or increased loss either in renal such as DI or osmotic diuresis, or in extrarenal conditions such as diarrhea or sweating as in cystic fibrosis. So as is understood, in extrarenal causes, you will have decreased urine sodium and there will be dehydration. While when there is a case of actual sodium load, which might be due to endogenous increase in aldosterone or an exogenous sodium load such as a not properly diluted ORS, etc., your urine sodium will be high and there will be fluid overload. Next. So when we approach a case of hypernatremia, so slides are not visible. So first thing, we need to rule out whether there is any condition leading to salt load or diabetes. The next is our, we need to check the urine osmolality. Yes, it's visible.
Yeah, okay.
So after ruling out conditions of salt load or diabetes, next step is to rule out urines or to measure urine osmolality. So with hypernatremia, ideally urine should be hyperosmolar. But if it is hypoosmolar, then this condition is known as diabetes insipidus. And to differentiate between central cause of diabetes insipidus or a nephrogenic diabetes insipidus, we need to give AVP, we need to see for the AVP response. As already discussed, with hypernatremia, we have hyperosmolar urine. Once hyperosmolar urine is present, we need to check for urine sodium. If urine sodium is low, then there are some extrarenal loss cases such as diarrhea. And if urine sodium is high, then we need to check for renal losses. With the help of few cases, handing over to Dr. Ria from here.
So 3-month-old girl with altered sensorium. This is a case who presented to, and this is not an uncommon presentation, now coming to us with severe dehydration, altered sensorium and a sodium of 170 and potassium of 4.2. Urinary osmolality at this point of time was found to be low. And this child was advised water deprivation test, was referred as quote unquote DI and sent to us for water deprivation test. Now, Dr. Mahesh, would you like to do a water deprivation test here?
You're mute, sir.
Yeah, Dr. Mahesh, will you like to go ahead and do a
Yeah.
water deprivation test?
Yeah. No. I will like to know about why the child has, whether he was only breastfed child or top-fed child. And top-fed child, whether it was properly made powder 30 ml per the scoop was made or something else was done. And that is responsible for his hypernatremia. That is one cause I would like to rule out prior
Yeah.
to doing any test like that, history-wise.
So, yeah, so there was child was a completely breastfed child. There was no history of any top feeding.
Yeah. So now in this case, such a severe hypernatremia and urine osmolality is only 110. That is too low for that hypernatremia. It should be above 600. So you should conserve water because it is a water deficit in this case. It is causing such a high sodium. So and itself a sodium of 170 will not require any water differentiate. This itself is a test for that child.
So we
So, and
clearly
in
have,
such a small child, you should not do water depression test. That is one more contraindication.
yes.
The higher sodium, small babies, you should not do water depression test.
So the aim of
And
water deprivation is to make sodium above 145. His
yeah, and it
already
is already 170 here.
nature has done the water deprivation in
Water.
the
So
child.
you should not do, or you will get into soup by doing water
The
depression test, or
child,
he will
and
may
in
have
fact,
seizures and all this.
I will give you a very interesting story that around 15 years ago, I got a case report in which they mentioned that they did a water deprivation in somebody who has a sodium of 170,
Oh,
and then they developed seizure. So they had actually reported that. So it's like you have killed somebody and then you are going to the police and say that you have killed it. So it was
yes,
like, how can you report such a case? So this was something which you should definitely, absolutely
should not do.
avoid on that regard. So
Yeah,
in this case, obviously child will develop seizures, and this is something which is not there. You already have a concentrated blood and a dilute urine, so DI is already diagnosed. You don't need to
yeah,
worry about this and make a diagnosis, do a ABP response, and
yeah,
this was labeled as central diabetes insipidus.
yeah. And this is a male child.
It's a male child.
Yeah, male child can have, it is nephrogenic diabetes is X-linked
Yes,
recessive.
yes, yeah. But this is
So
more
yeah,
likely to be they turn out to be a malformation, a CNS malformation causing the central DI. So
okay,
key
okay.
messages, Dr. Mahesh.
Yeah, you should not do water depression test when the sodium is already above 145, and in a small child also you should not do because they will have suddenly deteriorate sometimes. So these are the contraindication to do water depression test. And with such a high sodium, if urine is not concentrated, the DI is the diagnosis.
Thank you, sir. Moving to case number 8, a 14-year-old girl child presented with a failure to thrive. Her birth weight was 2600 gram. Now she is only 2300 gram. She was exclusively breastfed. The sodium was 182 millimole per liter and urine osmolality was very high, 1000 milliosmol per kg. So I would ask Dr. Amit sir to approach this case.
So what we have a 14-day-old girl, and actually, at least by 14 day, the baby should have regained the birth weight. Baby has actually lost it, and sodium actually is in life-threatening condition. 182 is very high. So the approach would be definitely first we have to look for osmolality, which is high, as you have told, it's 1000. Then the second step would be to look for urine sodium, which again is
110.
very high, 110, as you have shown. So what we have is it must be some excess sodium load, and in a case with it seems to be like a breast milk related hyponatremia, and it's very usual in primary gravida patients where it is not actually due to that breast milk is having excess sodium. It is that baby is not getting the breast milk which the baby should get because of maybe due to decreased production, or maybe the mother is not knowing how to feed the baby well. So it is actually very life threatening. And if we have condition like this, the only thing which we should go straight away is for dialysis, because the baby may die very fast. And uh, the prevention is the best thing to do, because once this condition is developed, again very difficult to treat. Yeah.
So how would you like to prevent this, Dr. Amit?
So, the two things which we can do is all primary gravida patients' mothers should be counseled beforehand, and second, that all the babies at 14 days, the weight should be done, so that we should look if the baby is having proper weight gain or not.
That is very important. So in Australia, they used to routinely do it at 14 days to check for the weight, whether they have regained or not, because this is condition typically comes around 3 weeks.
Yes.
I'm sure everybody would have seen 1 or 2 cases like that, and this could be lethal. It's very, very difficult to save them.
Yes.
Sir, so the key message is high. So your serum and urine sodium is matlab, high sodium.
Yes, yes. So already told that the same thing, when we have high serum with high urine sodium, excess sodium load should be considered. And as already told by sir, breast milk hyponatremia is something which we all have seen and maybe we have missed, and it's very lethal. So best to prevent it.
It's very common in primary mothers.
Yeah.
Case
Sir,
number
any other cause, sir? Sir, Anurag, sir?
Such early onset hypernatremia, the most common causes would be some structural abnormality which is there in the hypothalamus causing DI. That will be a
Okay.
presentation. Your urinary osmolality will be very, very low. So that is something which is going to be easily picked up. These will be the two major differences of severe hypernatremia in the neonatal period. Now, I would say that, yeah.
Okay, and there is something like that cholesterol sodium is high and it is not then subsequently lowered down. Because of that, they will get this hypernatremia in some mothers.
Yeah, so we actually reported when I was a resident, we found this case and I worked out the case and we got the diagnosis right. So at that time, we speculated that it was because of the high sodium in the breast milk. But actually,
Okay.
then we realized that the milk production was so less that even if
Okay.
we take the whole sodium, it was like, I think, 100, 200 in the breast milk. But that is also dehydrated breast milk. So what we're trying to say that inadequate production of breast
Okay.
rather than, so it's more of a dehydration state rather than
Dehydration. Okay.
and just as a key message, when you talk about sodium disorders, we are mainly talking about problem fluid.
Water.
Too much water causes hyponatremia, too little water causes hypernatremia. When you talk about dehydration, you're talking about sodium problems. If your sodium is too much, you have overhydration. If your sodium too less, you have in that sense dehydration. So it's the other way around when you work out from that perspective. So this is mainly a free water issue, and because the amount of breast milk was very minimal in the mother in that.
Okay. Thank you, sir.
Moving to case number 9, a 13-year-old boy with encephalitis was on ventilator. He developed polyuria with output of 10 ml per kg per hour. Sodium was 180 millimole per liter and urine osmolality was 120 milliosmol per kg. Post AVP, the urine osmolality was 200 milliosmol per kg. So I would like to ask Dr. Varuna ma'am to approach this case.
So clearly this child has polyuria and with the hypernatremia. So he's having a lot of free water loss. And like they say already the water deprivation test has been done because when the urine serum of sodium is more 180, which is way beyond the normal limit. And when we calculate the serum osmolality, also the first component is 2 into sodium. So already serum osmolality, if we see 2 into sodium, is way beyond 360 milliosmoles per kg. So with that you have a urine osmolality which is still low. So the patient is having a DI, and when you give AVP from outside, there is some improvement in the urine osmolality. So there is a possibility of a central DI, and considering that this child is on having encephalitis, that is probably the cause of the central DI. So this is this is clearly central DI, and this patient will need management with fluid replacement, as well as we have to give AVP and try to attain equilibrium where the patient stays well hydrated and eunatremic also.
So what is the key messages in this case?
So when one is, of course, that we should consider a diagnosis of central DI in such cases, especially with neurological involvement. Also, there is a possibility that this patient could have suffered brain death related diabetes insipidus because of the brain injury, because of the encephalitis, may be seen in other conditions as well. And of course, fluid replacement with AVP infusion is the treatment, and we have to achieve a balance with the two to ensure that the patient is euvolemic and eunatremic.
And I think that's very important message is that if you have a DI, it means that the extensive area of hypothalamus has been damaged. It's like 4 centimeter area. So in a diffuse brain injury, it means usually that the whole brain is damaged. So I think that's an important point Dr. Varna said, that brain death could
Sir,
be. Yeah. Yes, Dr. Mahesh.
Anurag sir.
Yeah.
Yeah. So you said that it is a brain dead DI, means already brain is death, or we should stop ventilator, or we should withdraw ventilator. That is a meaning of that brain dead DI, or we can continue to treat or do EG, twice EG, and then we should decide.
Yes, so it's just a nomenclature perspective of brain death.
Yeah.
So it's a very extensive brain damage, and often the
That
outcome once the
means
area is
that
damaged
very
is very poor.
extensive damage causing DI. That's
Yeah,
all.
it's a
It is not
prognostic
actually
bad
brain death.
prognostic. Yeah, it's a very bad prognostic marker. Yeah, in that regard.
Thank you, sir. I would like to hand over to Dr. Neha ma'am for further discussion.
Neha?
Yes, sir. So when we talk about hypokalemia, it can either be due to intracellular shift of the potassium ion, which can happen under the influence of insulin, beta agonist, periodic paralysis, or medications such as risperidone and quetiapine. There can be urinary loss or extrarenal loss. Extrarenal, as already discussed in cases of GI tract, such as vomiting or NG aspiration, or in cystic fibrosis. Urinary loss of potassium can happen either via RAS-dependent mechanism or RAS-independent mechanism. RAS-dependent can happen due to aldosteronism, Liddle syndrome, 11-hydroxylase, and 17-hydroxylase defects, whereas RAS-independent can happen due to tubulopathy or renal tubular acidosis. So on the basis of blood pressure, we can differentiate between the different etiologies. So moving on to the approach.
You able to see the slide?
So, yeah, to streamline the diagnosis of causes of hypokalemia, we need to look at 5 parameters: volume status of the body, urine chloride, alkalosis or acidosis, magnesium, and blood pressure. So magnesium levels are low in cases of diuretic use, malnutrition, Bartter and Gentleman syndrome. RAS excess defects will in particularly have high volume and high blood pressure. So with the help of these 5 parameters, we can downstream which of the causes can be there. Next. So moving on to the approach, as already discussed, based on the history, diuretic use, malnutrition, GI loss, we can get on the basis of history. If none of these is present, then we need to assess the blood gas parameters. If there is metabolic acidosis, then with the help of urinary anion gap, it can either be renal tubular acidosis if there is a positive anion gap, or a GI loss if there is a negative anion gap. Based on the blood pressure and the presence of metabolic alkalosis, if the blood pressure is normal, we need to look at the urine calcium levels, which is low in Gentleman and high in Bartter. If the blood pressure is high, then we are dealing with aldosterone axis, which need to see via plasma aldosterone levels, which is high in cases of RAS defect, whereas low in cases of DOC or 11-DOC defects. If the levels are normal, then we are dealing with either Liddleman syndrome or apparent mineralocorticoid excess. On the basis of few cases, it will be helpful to delineate the approach.
Yeah. So welcome, Dr. Ria, to discuss about the cases.
So coming to the cases, case number 10, a 2-month-old boy presented with hypokalemia of 2.8 millimole per liter. The pH was 7.16, BICA was 14 millimole per liter, and base excess of -16. Anion gap was 12 millimole per liter, and the differential diagnosis were diarrhea versus RTA. So I would like to ask Dr. Sangeeta ma'am to approach this case.
Thank you, Dr. Ria. So as we can see, 2-month-old boy with hypokalemia, and there is VG shows normal anion gap acidosis. So usually, as discussed now, hypokalemia is usually associated with alkalosis, but if there is acidosis, metabolic acidosis, we have to consider 2 conditions, diarrhea and RTA, and we have to differentiate the 2 using urinary anion gap. So if it is negative, then it points towards GI loss, and if it's positive, it points towards. Hello. If it's positive, then
Carry on, Dr. Sangeeta.
If it's positive, then it points towards renal tubular acidosis. So in this scenario, we can see urinary, if we apply the formula sodium plus potassium minus chloride, so we are getting a negative urinary anion gap. So it points towards the GI loss, usually the diarrhea. So in this scenario, we are dealing with hypokalemia due to diarrhea.
So what are the key messages, ma'am?
So as discussed, so with the low hypokalemia with metabolic acidosis, we have to think of two conditions: diarrhea, renal tubular acidosis, and urinary anion gap can help distinguish between these two conditions.
Thank you, ma'am. Moving to case number 11, a 3-month-old girl child presented with failure to thrive and hypokalemia of 2.2 millimole per liter. The birth weight was 2800 gram. Now it was 3500 gram. pH was 7.54 and BICA was 33 millimole per liter. BP was 70 by 40 millimeter of Hg. I would ask Dr. Mahesh sir to approach this case.
Yeah. As I'm a general practitioner, 3 months child, girl, 3 months girl, failure to thrive. I want to ask about other details. Why she has failed to thrive? Whether there was some cardiac problem, respiratory problem, or liver problem, or GI problem. Once you rule out all this, then this one will help. Hypokalemia will help. Can you go back to previous slide? Previous slide, yeah. Yeah, this one. Yeah. Now the child has hypokalemia, and what was his sodium? We are not discussing sodium right now. Okay, but birth weight is 2,800 grams, and she has gained only around about 700 grams within these 3 months. She literally has failed to thrive, and there is alkalosis, and bicarbs are 33. That is too much, and his BP is normal. In hypokalemia with alkalosis, we'll look at the blood pressure, and if blood pressure are normal and sodium is also low, then we are sure that we are dealing with tubulopathies. And with metabolic alkalosis, hypokalemia, tubulopathies are Barter and Jittermans, but Jittermans will come later on in a slightly older children. So high chances of Barter are there. So I will look at nephrocalcinosis in this child, ultrasonography to look at nephrocalcinosis. And if there is nephrocalcinosis, then we are on the spot that we are dealing with Bartter syndrome, maybe type 1, 2, or 3. Type 1 or 2 are more likely to be there because 3 will slightly present later on.
So
Now,
yes.
Yeah. Normal BP alkalosis, it is a Barter, and nephrocalcinosis is do. Nephrocalcinosis is because of hypercalciuria. And hypercalciuria and magnesium will be normal, sir, in this case. Anurag, sir?
Yeah, magnesium in this case was normal in this scenario.
Yeah. That is one more clue that we are dealing with Barters. Gentlemen will have hypomagnesemia. Am I right?
Yes.
Yeah. And sir, low sodium, low potassium, we are dealing with tubulopathy. And high sodium and low potassium, we are dealing with RAS excess or RAS alternate, like that.
Yes, thank you, sir.
Thank you.
Moving on to case number 12, an 8-year-old boy presented with signs of early puberty. The height was 134 centimeter, pubic hair stage was 4, pH was 7.52, BICA was 34, and potassium was 2.6. Urinary chloride was 100 millimole per liter, and BP was 120 by 74 millimeter Hg. I would like to ask Dr. Amit sir to approach this case.
Okay, so we have a 8-year-old boy with early puberty. Definitely height is on the higher side with pubic hair stage 4. And there's metabolic alkalosis as shown in the slide with very low potassium, 2.6. And urine chloride is on higher side, 100 millimole, which says that it is not chloride responsive hypokalemia. Urine chloride is again a very important marker of in the workup of hypokalemia. BP 120 by 74 is definitely higher for this age group. So coming to the approach already depicted, first we have to go for blood gas, which you showed that it is the patient is having metabolic alkalosis. Blood pressure is on higher side. Then we have to go for aldosterone level. So it's shown it was low. Then we have to go for DOC levels. And if DOC levels, what was the DOC levels like?
So it was high.
It was very high. In this case, presentation was very unusual. This was a child who presented to us with a boy as a precocious puberty, but there was cryptorchidism. So this is a very unusual scenario. So what do you think? Where is the testosterone coming from, Dr. Amit?
So it's like because of 11 hydroxylase deficiency, it's a case of CAH. And that androgenic pathway is functioning actually. And DOC being a mild mineralocorticoid activity it is having, so it's causing that like hypokalemia and metabolic alkalosis and hypertension.
Okay. So what are the key messages in this case?
So whenever we have hypertension with alkalosis, CH should be in the list of our differentials. And a case of hypertension can be in 11 hydroxylase and 17 hydroxylase also. But because the case is XX-DSD, because the patient was having cryptorchidism, so our differential would be 11 hydroxylase. So definitely hypertension with alkalosis, we should think about CH.
Yes, sir.
So thanks a lot, Dr. Amit, for this discussion. We have also developed tools for electrolyte evaluation in the form of our MediClasses application, wherein based upon just entry of the sodium and potassium, you will be able to then go run through the entire algorithm. So whatever we have discussed over the last 1 hour, all you need to do is to just put the values, like if you will know what are the basic defects with regards to every disorder. So it's a combined tool for all sodium, potassium, all abnormalities. So if you have hypernatremia with hypokalemia, the next normal potassium is asking for urinary osmolality, and then it's going like a DI. So this will give you a clear-cut picture. And again, investigations are being done on a priority basis. So this is just hypokalemia. As we discussed, first look at the pH. So this child has metabolic alkalosis. Bicarbonate is also on the higher side, and base X is also confirmed that this is metabolic alkalosis. There is no hypertension and magnesium level, and we are also giving age-specific reference values, which was found to be normal, and urinary calcium is on the lower side. So the higher side suggests to be Bartter syndrome. So this is the way these algorithms have been developed in that regard. So at this point of time, definitely we had a very wonderful discussion on electrolyte. I'd like to thank the entire team. We'll see if there are any particular questions there in Q&A. How does PCB is a marker of dehydration? So Dr. Ratni Vail, basically if there is dehydration, there will be hemoconcentration and hematocrit will go up. Transient cases of pseudo-hypoaldosteronism, in some cases obstructive uropathy. Dr. Rajesh, exactly, it's a common scenario. So you should treat it, correct the infection, correct the obstruction, and they will improve. Dr. Ratnivel is asking, why do we need to look for weight loss in 3 weeks' time? So it's basically to look at 2 weeks. So we want that 2 weeks the weight should be same. If the weight is not regained, we have to ensure that the child is not dehydrated. Dr. Rahul is asking, in case of hypernatremia related to breastfeeding, do we need to evaluate mother regarding same? So it's not really. We did a lot of workup in the mother to look for the mother had aldosterone deficiency, and that's why, because breast is actually also a modified sweat gland. So we are thinking that there is more sweat sodium coming in, but ultimately we realize that the sodium, even if it is coming too much from the sweat, it will not be enough to cause hypernatremia. So it's not the problem of the mother, it's a problem of lack of milk production, which is more likely as a cause in that perspective. So I think it was a wonderful discussion.
Anurag sir.
Yeah, Dr. Mahesh.
Yeah. High sodium and high potassium, you have said that the Gordon disease is only differential diagnosis.
Renal failure can also.
Yeah, renal failure, can it, I have this going to.
Really, but yeah, so I have seen a couple of cases of renal failure, but then the sodium is not very high.
Very high. In Gordon, it can go up to what age?
It can go to 170, 165, 170, that sort of levels also.
Okay.
Yeah.
That is not there in renal failure.
In
It
renal
will be 150 or maximum 155?
Yes. Not more than that. So generally, in renal failure, we expect fluid overload and cause hyponatremia, additional hyponatremia. But yes, I agree entirely with your point that you can have renal insufficiency as a cause. So you should get a creatinine done at that point of time. So I now thank all the participants, Dr. Neha for a wonderful presentation, Dr. Amit, Dr. Mahesh, Dr. Sangeeta, and Dr. Varuna, who really covered entirely the entire topic of electrolytes very well, and Dr. Ria for nicely conducting the session. We will now be moving towards the next scenario, and before we hand over Dr. Pradeep to present his initial presentation, I'd like to share this case, which is really important why we are discussing this so much. This 4-year-old girl with DKA managed with fluid and insulin outside had found to have hypokalemia and was treated with normal saline and insulin. Now, what happened was that this child developed arrhythmia, and the problem here was that there was no potassium given in the hydration phase. And this is something which is absolutely important in this case. Now, in India, we are considered to be low incidence country as far as the diabetes is concerned, but this is actually a misnomer. It is largely because we are not identifying a large number of cases, and the main aim of all these programs is to ensure that we have got a good diagnosis and appropriate management in that regards. DK in India, I would say, was more like 80% when I came. Now it will be more like 40 to 50%. So it's an improvement in detection, but still a lot of cases would be there. It's clearly the leading cause of mortality. And based on some estimates, approximately 50,000 children with type 1 will be missed every year. So we have got a wonderful panel of experts who will be covering DK over the next 45 minutes or so. We have got Dr. Pradeep, who is professor at AIMS Patna, associated with us for a long time. Dr. Vikas Mehrotra, who needs no introduction. He is working in the field of pediatric diabetes and endocrinology in Aligarh. We have got Dr. Pragya Somani, who is also working in Bhilwara in the Rajasthan region with regards to pediatric endocrinology, and Dr. Jyoti, who did a fellowship with us and now working in Nepal from that perspective, and Dr. Abul, who is assistant professor at Tamil Nadu. So we will hand over to Dr. Pradeep. You would like to present from your side the initial slides, Dr. Pradeep?
Yes, sir.
Yeah, so you can start off the initial one. The cases will take up from here. Yeah. Are you able to share?
Yes, yes. Just a sec, sir.
Yeah.
Is it visible, sir?
Not yet.
Sir, can you present from your side? I'll be.
Okay. Sure, sure. We will start from here. I'll be running the slides from here.
Yes, sir.
Okay.
Thank
Yeah,
you, sir. So, good afternoon, all. As sir has briefed a little bit about. Yes, so DKA basically is a condition where there is no insulin in the body or less insulin in the body, and that is long standing, which is going on in the patient, which leads to increase in counter regulatory hormone, that is growth hormone, cortisol, epinephrine, glucagon, and these all counter regulatory hormone, they try to increase the blood glucose in the body where already there is high blood sugar. So that ultimately leads to increased osmolarity, and ultimately, since there is no glucose available to the tissues for energy, so there is ketoacidosis, and ultimately that ketones in the body, high ketone in the body, it leads to typical ketoacidosis, rapid breathing, Kussmaul breathing, abdominal pain, and typical order of this DKA. And ultimately this high glucose lead to polyuria, and when there is water loss, there is loss of glucose, potassium, sodium, etc., and leading to hypokalemia, hyponatremia, and a typical feature of DKA. Yes, sir, next slide, please. So what is the impact of DKA? So it leads to severe dehydration, start maybe ranging from 5 to 7% to 10%. The issue is that the clinical examination about dehydration in DKA is very difficult. So we usually prefer, when we treat these patients, we usually prefer to treat one step lower. So if it is 10%, we should try to treat 7%. It also DKA leads to hyponatremia. So it's approx in a patient 6 to 10 millimole per kg. There is loss of sodium. So whenever we are correcting sodium, we should take on account the corrected sodium, not the sodium which is you are measuring. So if for every 100 milligram per deciliter rise in sugar, there is loss of 1.6 millimole per liter of glucose. It also leads to decrease in potassium. So for every 0.1 decrease in pH, there is decrease in potassium approx 0.6 millimole. So overall, there is 4 to 6 millimole per kg loss of potassium. So potassium, there are lots of mechanisms where it causes hypokalemia. So not only increase in this deficiency of insulin and metabolic acidosis leads to shift of sugar, this potassium from intracellular compartment to extracellular compartment. Other mechanisms like insulin, this dehydration, which leads to secondary hyperaldosteronism. So these all conditions, they lead to hypokalemia, and there is usually it when you see potassium, that potassium is not the actual potassium, because of low insulin and metabolic acidosis, whatever potassium is present is from the cell, that is not the actual potassium. So when you start treating these patients with insulin, those all potassium go inside the cell, and there is devastating result of hypokalemia. Yes, sir. And also it causes uh, hypophosphatemia. Now we keep our keen eye on not only hypokalemia and hyponatremia, but also hypophosphatemia. And in a condition where you are treating and hypokalemia is not getting corrected, so you treat with magnesium also. Yes. So when you start treatment, what is the impact of treatment on DKA? So initially, so we go through different phases. So you start with fluid, then you add insulin, then you add sugar. So there are lots of impact on the patient of DKA. So when you start with fluid, so the counter regulatory hormone gets lower down. So this leads to decrease in sugar, approx 50 to 100 to 50 milligram per deciliter. There is decrease in sugar. So in initial 1 to 2 hours. After that, after 1 hour of treatment, you add insulin. So further, there is a decrease in approx 50 to 100 milligram per deciliter per hour of sugar. And when the blood sugar ultimately goes beyond 300 milligram per deciliter, so you add sugar also, depending upon how much it is, you add 5% or 10% dextrose. So, so as the name is DKA, so we remember it with a table of 6, 12, 18. So we expect that sugar should go down approx 6 to 8 hours. Then ketosis should go down approx 10 to 12 to 15 hours, followed by acidosis to approx 14 to 18 hours. So that is the usual, the decrease in glucose, ketones, and acidosis is DKA patient when it is properly managed. What about complications of DKA? So as we all know that the mortality in DKA is basically because of cerebral edema. So what are the factors which lead to cerebral edema? So whenever a patient who presents in severe decay, it is found that many studies has already shown it. One study was also done at Kanpur, CDR Kanpur, that it shows whenever a patient is having severe decay at presentation, the mortality is very high because of cerebral edema. If the patient was treated outside with too much fluid, because we know that the patient of DKA presents we usually with pain abdomen and diarrhea, this dehydration. So it is often misdiagnosed as some sort of diarrhea and given fluid, too much fluid. So this leads to cerebral edema. Not only that, many outside our colleague, they because of acidotic breathing and etc., they give lots of bicarbonate. So that bicarbonate also leads to CNS acidosis. Not that, when you give lots of fluid early in this decay, so because of that endogenous osmol present in the brain cell, there is sudden osmotic shift. So that sudden osmotic shift also leads to cerebral edema. So what we can do to prevent that? Whenever a patient of decay comes, we should uh, so this cerebral edema causes high mortality, high morbidity. So we should always give the child a one step lesser and should go slow. And we should have mannitol with us. And whenever in doubt, you should give mannitol. So mannitol is in the cart of decay management. We should always have mannitol whenever we are treating a decay patient. So as I said earlier, when you give insulin, so the potassium, whatever it is present, it goes inside the cell. So it leads to hypokalemia. So we have to add this potassium when we are treating patients with DKA. And next, please. Yes. So for acidosis, acidosis in DKA can be because of either the ketosis itself, or maybe the child might be having hypoxia or infection or fluid which you are giving. We give normal saline, so you are giving lots of sodium and chloride, so that leads to hyperchloremic metabolic acidosis. So we have to see the why the acidosis is. So we have to see the timeline and why, how the acidosis is behaving and what can be caused, can be caused, depending upon the various parameter which we'll discuss later on, how we can differentiate between these causes of acidosis. Yes, next please. Okay, so these DK patients are also prone to various infections. It's a vice versa. The infection in a patient known to have diabetes, they lead to sick day and followed by diabetic ketoacidosis. Not only that, diabetic ketoacidosis also leads to decrease in immunity, and the patients are prone to infection. Since it's a hyperosmolar state, so these patients are prone to have thrombotic events. So thrombosis is very common, and phosphaturia and lots of other things, they lead to rhabdomyolysis also. So we have to keep eye on that also. Next, please. So when we should suspect a patient to be having DK, so any child who is having earlier not known to have diabetes, so any child who is having unexplained or the typical features, lots of eating but not gaining weight, lots of polyuria. Okay, so these patients, if they are having polyuria and dehydration, so diarrhea is not there, polyuria is there. What usually happens in diarrhea? The urine output goes lower side. But in a patient where there is no diarrhea but polyuria is happening and dehydration is there, so we should think about diabetic ketoacidosis. Any child who is having unexplained encephalopathy, no fever or maybe mild fever, so we should think about that. Any child who is having tachypnea but there is no chest sign, you are auscultating the child, we must auscultate the child. So a child who is having respiratory distress sort of presentation and you are auscultating, the chest is clear, so you should think about diabetic ketoacidosis. Any child who has got unexplained abdominal pain, we must think about diabetic ketoacidosis. So criteria for diabetic ketoacidosis, again, we should remember the DKA. So D is dextrose, that is sugar. So any patient having more than 200 milligram per deciliter of sugar. pH, venous pH of less than 7.3, or this bicarb less than 18, or ketone in blood more than 3 millimole per liter, or in urine 2 plus or more. So this is the criteria for diagnosing DKA. Uh, then there is severity criteria also. So that is based on pH. pH less than 7.3 mild decay, less than 7.2 moderate decay, less than 7.1 severe decay. Similarly, less than 5 is severe decay, bicarb, less than 10 is moderate decay, less than 18 is mild decay. So what are the danger signs? So we must rule out sepsis whenever we are treating a DK patient, and at presentation, every child we should see, since potassium is a point of care test, so we must see potassium at the time of presentation, and whenever there is hypokalemia in ECG or in blood, so we should defer insulin. Whenever you are thinking sepsis, you must treat sepsis or fever, you must treat at the start of your treatment with antibiotic. When you are suspecting cerebral edema, you should give mannitol and you should slowly correct DKA. Next, please. Yes, hypertension may be common in DK. It is commonly present in DK, but whenever it is associated with decrease in urine output and you are thinking about AKI, so this has to be kept taken in your mind. So it can be because of AKI, or if typical Cushing stride is present, so respiratory, abnormal respiratory pattern, hypertension, and this other features are there. So you think about cerebral edema. Other normal things are that mild increase in this TLC is there in decay, so you don't have to worry. Slight high amylase and lipase can also be present in decay. Okay. So what about stabilization? So initially we have to think about certain thing which we don't have to do. So we normally as we see the pulse algorithm or IPLS algorithm, we should stabilize the child. And in a child where you are thinking about decay, you should not start initially with the sugary drink. Okay, we every decay child we have to put two wide bore needle. We should avoid putting central line because there is high thrombosis risk. So wide bore needle, oxygen has to be given, and intubation has to be avoided because at presentation that decay child looks encephalopathic, but when you start treatment there is dramatic magical improvement. So the sensorium of the child improves faster. So even slightly the GCS is slightly towards marginal, we should avoid intubating the child, and we should avoid this fluid overload to the child because that will lead to risk of cerebral edema. Yes, next please. So what we have to monitor, naturally cerebral edema is the leading cause of death and decay, so that we have to monitor in terms of ABPU scale or GCS. Dehydration should improve with the treatment, that we have to monitor. So AKI in each child where there is decreasing in urine output in spite of treatment, so we should think about AKI and accordingly we have to manage. Sodium fall is not there in the decay, but if it is rapid fall, so we think about cerebral edema. Potassium, as I said, when you give insulin, there is risk of potassium. So at presentation, what is the potassium that is important for us? So hypokalemia is expected in decay. So we should supplement with that. And we should start insulin after 1 hour, correct, seeing potassium. Insulin we should start to a bit lower side, and we give insulin infusion accordingly. Please, next please. So this criteria, the whole talk is based on the ISPAD's latest guideline 2022. Yes. So we switch over to the cases. So lots of interesting cases are there. So that will clear the whole management about decay. So first case is a 4-year-old girl who is presented with severe decay.
Yeah, so Alapan will start the cases. You keep giving
Okay, sir. Okay, sir. No problem.
Alapan.
Thank you, sir. Start with the case number 1. A 4-year-old girl child with severe decay managed as diarrhea and referred. The blood gas picture, we can see the pH was low with ketone of 7.1. The patient was drowsy and anisocoria was present in the eyes and the reflexes was brisk. So Dr. Jyoti ma'am, I would like to know how would you like to manage this case?
Thank you. So, this 4-year-old girl with severe decay, who is drowsy, anisocoric, and having Brick's reflex, with severe metabolic acidosis with bicarb of less than 10, and with high ketones, so who has been managed outside. So we have to think of child is suffering from cerebral edema.
Okay. So how would you like to manage this case?
So in such case, we have to straight away go for the mannitol, and we have to go for the slow correction of fluid, which is to be done over 72 hours.
Thank you, ma'am. Moving on to the next case, a 11-month-old boy presented with failure to thrive. pH is 7, ketone this time is 4.4, and blood sugar of 440. So, Dr. Pragya, ma'am, I would like to know how do you like to manage this case?
Ma'am, you are mute. Please unmute yourself.
This child, 11-month-old boy, fulfills the criteria of diabetes, ketosis, and acidosis. So obviously, this is a case of decay. But as the age is very small, just 11 months, we need to take care while treating this child. So we have to give a bolus as per the protocol. And then over next hours, over next few hours we'll add insulin, but insulin will be added in a lower dose of 0.05 unit per kg. And the correction will be over 48 to 72 hours. And the main precaution we have to take is that the younger age group kids are prone to cerebral edema. So this is a slide about low dose versus standard dose of insulin. low dose is offers a slower correction and gives a benefit of lower chances of hypokalemia. So it is better, especially in younger children.
So, Dr. Pradeep, what is your take on the lower dose of insulin?
Yes, sir. So this study, which was conducted in PGI Chandigarh, they did, since the sample size was a bit lower side, 50, 25, 25. So they did non-inferiority trial, and they found that there was no difference in treating when they were considering 0.05 unit per kg or 0.1 unit per kg. So they had seen the slow decrease in or falls in blood sugar, which we expect, because if there is sudden sugar fall, so there is high chance of osmotic shift leading to cerebral edema. So, and another thing is that the chances of hypokalemia was lesser in this lower group. So patient to patient, we have to think about whether we should go with low dose or this standard dose therapy. Yes, sir.
Thank you, sir. Moving on to the next case, a 9-year-old girl child with she is quite emaciated. RBS was more than 500, 600 milligram per DL. pH was in acidotic range 7.1 and ketone of 4.2. So, Dr. Vikas, sir, I would like to know, how do you like to manage this case?
Thank you, Dr. Arappan. She's a typical case of diabetic ketoacidosis. We have got hyperglycemia. pH is quite low, severe acidosis, and ketosis is very high. So, and the child is emaciated. So, we have to be very, very careful as far as the initial hydration phase is concerned. Because if we concentrate on initial hydration phase, we can supposed to give boluses only if child is hypovolemic shock or blood pressure is on the lower side. Otherwise, there is no need of any bolus. Insulin we are considering again in the lower dose, and we should add the insulin only after initial rehydration phase, because it has been seen that initial rehydration will lead to correction of hyperglycemia up to certain extent as well as the acidosis. So insulin should be added in a lower dose after initial rehydration phase, because, and we have to be very, very careful about hypokalemia, because younger child, emaciated, severe diabetic ketoacidosis, she will end up, or rather, she will be she has been in hypokalemia. So insulin should be delayed after initial rehydration phase. Correction of rehydration is very, very slow over a period of 48 to 72 hours, and boluses, yes, if the child is in shock. Over to you, Pradeep.
Before we proceed, I request Dr. Abul, if you are driving the car, please park your car before answering.
Okay.
Yes. Yes, Alpan, please go ahead.
So moving on to next case, 3-year-old boy with severe decay managed as diabetic ketoacidosis for 6 hours. Now the pH is 6.9 with a ketone of 6.4 and bicarb of 5. Potassium is 2.8 when he presented. So Dr. Abul sir, I would like to know, how do you like to approach this case?
So here potassium is only 2.8 millimole per liter in the case of severe DKA. So at presentation, there may be hypokalemia or normal potassium, or sometimes potassium may be more than 5.5 millimole. So if you have potassium hypokalemia should be corrected first, because hypokalemia is more dangerous than acidosis. So you want to give bolus 20 millimole of potassium with the initial bolus, and with the fluid 40 millimole per liter in a fluid, correction fluid. So if potassium is 3.5 to 5.5 millimole, you should add 40 millimole per liter in correction fluid. If the potassium is more than 5.5, no need to give potassium until urine output is normal. So first you should start correcting potassium at the hydration phase. This is the point.
Sir, moving on to the next case, 10-year-old girl child with a blood sugar of 540, 30 kg weight around, and the base excess was minus 18. This time potassium is 5.8, the pH of 6.9, and the treating clinician had found that the dehydration was 10%. So Dr. Jyoti ma'am, I would like to know, how do you like to manage this case?
So this is a case of severe decay with pH of 6.9 and base excess of -18. So we have to manage such cases in intensive care units, and fluid bolus should be preferred before starting insulin therapy. And we have to give the fluid bolus normal saline 10 ml per kg, which is to be given in half an hour to 1 hour. But if the child is in shock, we have to go for the faster correction, and we have to deduct that fluid from the total fluid, which we'll be calculating. And along with that, whenever we are managing, we should avoid more than 2 boluses, and the rate of infusion of the fluid should be less than 40 ml per kg in 4 hours. And we calculate fluid according to the SPAT guidelines. In that, we usually calculate maintenance fluid requirement and deficit fluid requirement. Maintenance fluid requirement is given according to 4:1 formula. So, as you said, this is a 30 kg old child. So we calculate the maintenance fluid, which come out to be 70 ml per hour, and there is a 10% dehydration. And on calculating like 10% dehydration for 30 kg, it comes out to be 62.5 ml per hour. So the total fluid which is given in 1 hour would be 135 ml. Along with, after managing with the fluid, then we go for the insulin, and we start with the low dose insulin 0.05 units per kg per hour, so which comes out to be in 30 kg 3 units per hour. Along with this, since the potassium is 5.8, we give potassium chloride, that is 40 millimole per liter, which is to be added.
So,
Thank
father,
you.
of this case, after 4 hours, the blood sugar remained like 650 milligram per dl with base excess of -22. So, Dr. Pragya ma'am, what are your thoughts about this case after 4 hours?
I think, Dr. Alappan, we have already given the hydration phase. We have started the insulin, but still, if the sugars are not lowering and base excess is still on higher side, so there can be either either the insulin is not being given properly, or the tubings are absorbing it, or we are giving too little insulin. So there is we have to take care while giving insulin, that we have to give it in proper doses. We have to dilute it properly, and very important, we have to flush the tubings. And also the patient could be going in shock, so we have to take care about this parameter also.
Thank you, ma'am. Moving on to the further follow-up of this case, at 8 hours, the blood sugar become 190 milligram per dl with base excess of -12. So, Dr. Vikas sir, now how would you like to manage this case from here?
Thank you, Dr. Arpan. If you analyze the parameters, so child still has got acidosis, but the sugars are going down. So if this is a tricky situation, if you are stopping insulin over here, that will lead to prolongation of acidosis. So you cannot stop the insulin. So you have to add the dextrose, because you don't want to be your child to become another emergency situation of hypoglycemia. So you have to continue the insulin and addition of dextrose. That's why I always recommend that if you are managing a case of DKA, the mannitol and dextrose vials are always be at the bedside. And the protocol for adding glucose and adding dextrose to the eye fluid is, if your sugar is around 300, you need not give dextrose. Keep following your insulin regime. Between 200 to 300 milligram percent, add 5% dextrose, and less than 200, give 10% dextrose. So the message from this slide is that if you want to avoid persistence of prolonged acidosis, you have to continue the insulin, but taking in the mind of hypoglycemia, and manage hypoglycemia according to by addition of the dextrose as per the protocol. Thank you.
So moving on to the next follow-up of this patient, at 10 hours, the blood sugar is 220. This time base excess is getting up, is -11 with potassium up 2.6. So Dr. Abul sir, I would like to know how do you like to manage this case now?
So again, potassium is in lower side. So potassium, the child has hypokalemia. So same thing. If potassium is on lower side, less than 3.5 millimole, in bolus fluid, you want to add 20 millimole, or in hydration phase fluid, we can add 40 millimole per liter. If the potassium is normal in the range also 3.5 to 5.5 also, you can add 40 millimole per liter of potassium in the fluid. You should avoid in case of if the potassium is more than 5.5. So the intervention here is you should delay the insulin. First you should correct the hypokalemia and then you should start the insulin. Thank you.
Moving on to the next follow-up, 14 hours, the child is now comatose. So Dr. Jyoti ma'am, what are your thoughts regarding this and how do you like to manage this from here?
So any child who shows a sudden deterioration after improvement, in a case of decay, we have to think of the possibility if the child has slipped into cerebral edema, because there was a fluctuation of sugar, which we are seeing in such cases. So rapid fluctuation of sugar, which lead to osmotic shift, and that could have led to cerebral edema. So in such cases, if you find the child is suffering from cerebral edema, in those cases, we have to immediately go for mannitol infusion, and we should not waste time for imaging, which could be lethal in such cases.
Thank you, ma'am.
Okay, this is one of the study which is showing that cerebral edema is common at admission in Indian children and should be suspected in subject who are having severe metabolic acidosis and prior fluid treatment, and there is a need for early detection and uniform protocol based management to prevent the complication.
So I think if you have a child who comes to have treatment from outside, whose CO2 is less than 10, who has a pH less than 6.9, and a young child, always be wary of cerebral edema. And Western figures say that it happens only at around 12 hours of admission. But in our setting, because the patient has already been treated, we can have it right at admission as well.
Thank you, sir. So moving on to the follow-up of 20 hours. Now the blood sugar is 190 milligram per DL, but still the base excess is minus 12. So Dr. Pragya ma'am, is the child is deteriorating or what is happening with the child?
What we can see is sugars are improving, but acidosis is still persisting. So at this hour, we'll go for measure the ketones. So here we can see that ketones are normal. And anion gap is also around normal. So this appears to be hyperchloremic acidosis. So acidosis at this stage can be ketoacidosis, can be due to lactic acidosis, or can be due to hyperchloremic acidosis due to excessive administration of chloride ions in form of sodium chloride and potassium chloride. So we have to be aware of this, and we have to treat it accordingly. And bicarbonate administration is not recommended except for treatment of life-threatening hyperkalemia or for severe acidosis, because there is an evidence of increased complication rate with administration of bicarbonate.
Thank you, ma'am. So moving on to next 28 hours at blood sugar is 170 milligram per DL. Base excess is now minus 4. The child is conscious, feed and food orally, and shifted to regular insulin 0.3 unit per kg subcutaneous. And concurrently, the fluid and insulin has been stopped, but after 2 hours of blood sugar measurement, the blood sugar goes up to 560 milligram per DL. So, Dr. Vikas sir, I would like to know where did we do the wrong thing here?
Thank you, Dr. Lappan. See, there's the right time your child is fully conscious. You have allowed him orally. So there's the right time to introduce the basal bolus regime. And what we did is we stopped the, can we have previous slide, please? Okay, fine. So what we have done is where we have stopped the fluid and insulin. Okay, fluid can be stopped, but it is better if we cover the child with the basal insulin 12 hours before and before tapering off the IV insulin, so that there's some amount of basal insulin in the body. And since we all know that after decay the requirement is quite high, so this will allow us to step into the rebound hyperglycemia. So what we should do is before stopping the insulin fully, we should overlap this IV insulin regime to our basal bolus regime. Before one night, around 10 to 12 hours before the stopping of the IV insulin, you should always give basal insulin, and then you can cover the meals by in form of subcutaneous insulin. And you can use either regular one, or as far as myself personally is concerned, I am using Novorapid or a short-acting insulin, so that child can be sensitized in a very early stage. That is the only regime which is available for this child. We should not supposed to give any other option. So timing is again with the meals. Increase the insulin rate if it is snacking, long-acting insulin one night prior. So that's all we have discussed. And secondly, even after you have given you have started basal bolus regime, you are covering the meals, you are giving the basal insulin. Try to continue the infusion in a tapered dose for next 30 minutes by closely monitoring the anion gap, blood sugar, level of consciousness, and other parameters. Thank you.
Thank you, sir. So moving on to next part of this case, the post-decay, the child was prescribed sliding scale of 2 units per kg per day with a fluctuating sugar level presented to us. Dr. Abul sir, I would like to know how do you like to manage this case on the child is on rightly like on post-decay.
Dr. Abul, please unmute. Please unmute.
Sorry. So after the acute phase, we have corrected, we have stopped the insulin infusion. After that, they followed a sliding scale. So it's while following the sliding scale, there is a roller coaster like effect. So sugar will be increased at one point, and it will be severely decreased also. So every time we will note after the increase only we are going to give insulin. So it is not an apt method. Sliding scale is not an apt method to correct it. So it will have fluctuating sugar. So we should be switching on the patient to the very good regimen called basal bolus regimen with the glargine and lispro. So post-decay patients should not be managed with the sliding scale. Should be started on a basal bolus regime.
Sorry, Dr. Abul, I am interrupting you. Even some people are using the sliding scale on basal bolus. Basal bolus is a regime. Scale is different. What is your view about that? Sliding scale on basal bolus. Basal bolus is a regime, and there are people who are using sliding scale on basal bolus. I request Dr. Vajpayee to kindly throw light on this.
They're using
this. Very important.
They're doing it that they are correcting for the glucose levels, because sliding scale means hourly. It is not related to meals or anything. But when we we are giving with meals, so of course, if somebody is very expert, they can use the carb count and the glucose level and do the calculations. But generally, we tend to be not giving that much information right at the beginning, Dr. Vikas. What is your suggestion?
Sir, what I do is, when the child is out of decay, since we know the requirements are high, I try to give a higher dose of basal insulin, so that we have got some residual as well as in between, as well as the child might not have another episode of decay, because initially what they are doing, they are not covering the meals properly. So the basal insulin in the body on board will help to avoid another episode first. Secondly, I started with a basal bolus with a fixed dose schedule, and then ask them to make a 7-point program if they are using SMPG or a CGMS. And then according to sugar, we keep on reviewing, and finally it will take around 10 to 15 days to reach on the final dosing for the child.
And
Your take, sir?
Yeah, we clearly know that the requirement will be very high to begin with, and it will come down. So we have to be very cautious. In the first 1 month is going to be a lot of changes, but it requires a lot of effort, not only on part of the patient, the family, but also the doctors. So Dr. Abul, your suggestions as to how should we improvise the care in this period?
Sir, I can't get you, sir. What is it?
So yeah, so you would like to start right away with a basal bolus with a high dose of insulin.
Yes. Yeah, okay, sir. Yes, sir. Yes, sir.
Okay, thank you. So we have discussed a lot about decay, and we have been discussing about decay for a long time. But what is known is that despite all that, there are substantial number of errors which are happening in management. So this was a study which we did a few years ago in our center, and despite a written protocol and multiple information which were being done, 82% first prescriptions had some error, minor or major, And these errors resulted in a 2/3 of hypoglycemia, around a half of hypokalemia, and 2/3 of dehydration. So even a tertiary center which is seeing high frequency of decay, the initial first hour management, which is crucial, may be erroneous. So what should be done in that regard is we developed this mobile application as part of our interpreter, which provides guidance with regards to the initial management. So based upon the initial database with regards to the age, the weight, the blood sugar, the ketone, it will specifically tell us whether the decay is there or not, whether this requires any immediate assessment, immediate interventions or not, and also on follow-up. So these are tools which will improve the quality of care from that perspective, which we have developed in that regards. So just to summarize, decay is a tightrope. If we give too little fluid, we will have dehydration. If we give too much fluid, there will be cerebral edema. If we give too little insulin, there will be delayed correction. If we give too much insulin, there will be hypokalemia. Now, anybody can decide that whether you want somebody in the ICU for a longer period and a bit dehydrated, or you want them to die because of cerebral edema or hypokalemia. So clearly, less is more in decay. We want less intervention rather than more intervention. So less fluid, less insulin, and maybe the use of technology will help us in personalized precision medicine care from that perspective. So I'd like to thank all of you and invite you to go to have a look at our website, which is a lot of resources, our mobile application, as well as our publications which are available from that perspective. So I'll take words from Dr. Pradeep about the further aspects of decay. He want to add on that?
Yes, sir. So we have covered almost everything, but the care should be individualized. And the little things which are important, like flushing of tube before starting it, using too wide bore needle, cannula. Then post decay, usually the glucose lowers down the first. So people think that the decay has got corrected. So until the acidosis gets corrected and everything is all right, please don't stop insulin. Give sugar, dextrose along with insulin, and provide time, proper duration to settle it down. And followed by that based on the financial status of the patient, you should decide what the next has to be done for the patient. So that is my take. You give option for pump, then you give this basal bolus with pen, then this regular, etc., etc. Yes, sir.
So thanks a lot.
May I have one small submission? See,
Yes.
what I have seen practically is the residents and my RMOs and parents, they are chasing sugars. They are very apprehensive and chasing sugars. Like, Dr. Sugar बहुत high चल रही है, sugar बहुत high चल रही है. And we have discussed and we have seen that monitoring sugar has got least monitor parameter of the blood sugar are the least bothering us. So I request we all know everything that we should not chase the sugars while managing the decay. This is my take, sir. What is your take, sir?
I think
Or every time they are apprehensive, parents are apprehensive, sir, sugar बहुत ज़्यादा हुई है, and we are least bothered about the sugar. So we should not chase the sugar.
Yeah, of course, sensorium, urine output, heart rate, sodium, potassium, much more important. And so that is a part of the management, I think. So this has been a wonderful discussion. I'd like to thank Dr. Pradeep for giving a wonderful talk, Dr. Vikas, Dr. Abul, Dr. Pragya, Dr. Jyoti for their inputs, and Dr. Alapan for the case discussion. We have had an extensive 2-day session covering around 7 modules, and today we are actually half an hour before time. So it's been very precise in terms of the modules, so that's very good. I'd like to have quick feedbacks of all at the end. So Dr. Pragya. You're muted.
Mute.
Sir, it is always lot of learning and very good experience to go through. I think many people are benefited by this. And I have been seeing that with these programs, most of the patients, even if we are referring to someone who has learned through these protocols, they are being managed on a similar platform. Like, it's not that if we will send it to someone, the patient will be managed from the beginning again. Or like recently I had a patient of short stature and he was from Bengal. I talked to Dr. Sumana and sent it to him, sent the patient to her. So I had managed the patient till a particular level, and then she went with growth hormone stimulation test. So I think it was definitely very beneficial for the patient, at least, that Same protocol is going on from east to west and north to south. So that is really amazing.
Ultimate aim that we have got a standardized care, right, not only from, let's say, a district level, but even at a PHC level. If we are able to have a DKA patient, they should receive the same care which is provided at any tertiary level, because all you need is fluid, you need insulin. That's not a very big deal. They can manage it very well in a triad system if develops, in a hierarchical system which will have two-way communication. That's a very important point that you brought out from that regards. Dr. Jyoti?
Yes, sir. So it's always like fruitful attending such sessions, sir. And it's like revision for me attending this webinar. So today, because of my OPD schedule, I was not able to attend, but yesterday I was throughout in the sessions. And thank you so much, sir. And I hope such learning will continue in future as well. Thank you, sir.
Thanks, Dr. Jyoti. Dr. Abul?
So I'm very happy to be a part of this program. So you have given me a chance again after our course. So I'm very happy that I'm continuing the learning process. Thank you very much.
Thank you, Dr. Abul. Dr. Vikas?
Always been a pleasure to learn. By every time I talk to Dr. Bajpayee and the team, Dr. Pradeep, Dr. Pragya, so so heartening to meet all of you. And I wish ki the day I joined Medi classes, it's a rebirth of me from intensivist to, I don't know, I should not call myself endocrinologist, but still we are trying to do something. And I've seen, you see that the slides of sir 4 months before, and believe me, there will not be any overlap in the next time. Topic remain the same, but the innovation and the research work is really inspiring. All the youngsters should learn how you can inculcate, like Dr. Pragya has already said, from east to west. तो एक भारत कर दिया और पढ़ाते पढ़ाते कर दिया, तो कुछ बोलने को बचे ही नहीं. अब दिसंबर में आ रहा हूँ, मतलब वो साल के दो जो चार चार दिन के वो होते हैं, जो स्लॉट होते हैं ना, मतलब दैट इज द रियल. मेरे पास शब्द नहीं है. डॉक्टर वाजपेयी, आप ऐसे काम करते रहिए, बस मेरी शुभकामनाएं आप.
Thanks, Dr.
Thank you.
Dr. Rashmi is there from Mysore.
Yes, sir. Good evening, sir.
Good evening.
Good evening, Dr. Rashmi.
Good evening. It has been a pleasure to attend your classes right from 2018, sir. So I'm really, I admire you a lot, and also the class I've learned a lot actually. And these grand rounds, these kind of PEC things, they are really very useful. And actually, many of my from my department have been expressing their happiness to attend these things, sir. It's been very useful. So I'm grateful to you.
Thank you, Dr. Rashmi. And Dr. Varsha?
Thank you, sir.
Thank you.
Yes, sir. Sir, it was very intensive and impactful course, and within the 2 days, we gained the maximum benefit in the very minimum time. Kudos to the organizer and you.
Thank you, Dr. Varsha. And Dr. Pradeep?
Thank you, sir. I'm still a student. I'm learning from you, and it's a team. जब भी हम मिलते हैं, it's not only learning, but we see faces of each other, and I'm very happy to see my team. And sir is my guru, and he will always be my guru. So thank you, sir, for giving me opportunity, and thank you all for being a part of this great learning session. Thank you, sir.
Dr. Pradeep and
प्रदीप एक बात और है. डॉक्टर वाजपेयी, प्रदीप सर ना क्या करते हैं, गुरुजी का ये है कि हर एक को एहसास कराते हैं कि आप ही डॉक्टर वाजपेयी हो. मतलब ही ट्राई टू, नहीं बिलीव मी, मतलब इतना हम्बल. मैं बहुत लोगों से मिला हूं, मैं 54 ईयर का हो गया, मतलब थोड़ा सा आदमी जान जाता है तो बस कहता है तो मैं तो गुरु हो गया. बट यार ही ट्राई टू एनकरेज यू बाय ऑल मीन्स. ये बता दें कि आप ही डॉक्टर वाजपेयी हो, मैं तो कुछ नहीं हूँ. स्लाइड इनकी, मटेरियल इनका, और स्पीकर आप बन जाते हैं. दिस इज वेरी, मतलब मेरे पास शब्द नहीं इस बात के लिए. सबको साथ लेके चलना, सबको इनकलकेट करना, सबको इम्पोर्टेंस देना, ये बहुत रेयर ह्यूमन क्वालिटी है. क्यों प्रदीप, एग्री करते नहीं करते?
Yes, yes. Thank you for that, sir. Anurag sir. Thank you, sir.
बहुत बढ़िया, रियल गुरु. हम भी हाथ जोड़ रहे हैं.
All the faculty who has been there for the last 2 days, a lot of participants who have been there throughout the 2 sessions, and most importantly, the team at Regency CDR who has been part of this. I'd like to thank Dr. Vibha, who was faculty yesterday, Dr. Alappan, Dr. Nimisha, Dr. Ria, Dr. Prashant ji is already there. He's always in the phone doing something or the other. And Nikhil. So all the team was in part of doing this work, and hopefully we'll be connecting in the on-site session in December, and then we'll carry on more activities from there. So once again, thanks a lot, everybody. And we will wish you all